Good morning. Welcome to our public or our board meeting held in public for Manx Care. We have apologies this morning from
Katie Capaneros and
Sandra Cardwell. So we accept those. Are there any additional declarations of interest pertinent to today's meeting that are not on our register that I should be aware of? No? Okay, thank you very much. I'd like to go through the minutes of the meeting, the last meeting held in public, which was on the 31st of October last year, which seems a lifetime away. And I'll take them page by page for any issues of accuracy. So going through page 8 in the pack, 9, 10, 11, 12, 13, 14, 15, 16. Oliver.
I think there's just a wee typo in the middle paragraph. OR queried whether this was the right way to present this data. I think that might be OE queried whether this was the right way to present this data.
Oh, right. You queried it.
I think that's what happened. Yeah.
Rather than you, Oliver.
It doesn't sound like something I'd
Great, so if we could change that, please, Elaine.
Yeah.
Page 17, 18. Okay, thank you very much. So we can accept those minutes as an accurate record of our meeting from October. If I move us on to the matters arising and our action log. Elaine, would you kindly take us through this, please?
Yes, thank you. So the first action, 62/23 July, and that was an action for Oliver Radford to speak to the Cancer Services team about proactively collecting qualitative data, and that's now completed and that's reported via our QSE committee. Second action, 79/23 September, the Manx Care record, that's the funding to be escalated to the board of DHSC, and that was done and the discussion was held at the meeting that was held on the 5th of September. Third action, 79/23 September, quarterly update on progress with CQC action plan to be brought to the board, and they've been diarised and the next one will be in March. And the final action is 80.23, the issue of dental provision to be raised at the mandate assurance meeting, and that was raised by Oliver and that action is complete. And then we have an action from the QSE committee, which was for Dr. Khan to attend the board to present on antimicrobial stewardship, and that will be done at the March meeting in public.
Thank you. Thank you very much. Does anybody have any items of any other business that they would like me to be aware of to raise towards the end of the meeting? Nope. Thank you very much. So we are joined this morning by a couple of colleagues from the Manx Heart Foundation. You are very welcome, Karen and Richard, along with Joe, who's one of our Associate Directors of Nursing. So I think you're going to come and talk to us about the work that's happening in the community and funding a clinical nurse specialist post within the organisation.
Yeah, thank you. Thank you for having us here today. Manx Heart Foundation has been a registered charity in the Isle of Man for at least 30 years under different guises. We used to be called the British Heart Foundation, you might have remembered, brackets Isle of Man. But in 2018 we officially changed our name to the Manx Heart Foundation to emphasise our Manxness and our commitment that all funds we raise stay here and are used on practical projects that will make a tangible difference to cardiac care. Over the years we've spent over £500,000 on necessary equipment such as ECG machines in the ED and in children's ward, blood gas analyzers, defibs, and of course our recent purchase, the new echocardiogram machine that is all singing, all dancing apparently. And that enables more patients to be seen, scanned, bringing down wait lists, etc. So the solutions we've provided have traditionally been in the form of hardware, actual machinery, tangible goods. We take on the financial risk of buying the new equipment, and Manx Care and Nobles takes on the responsibility of maintaining that equipment. And this model has proven over the years to work very well. However, in the last year and a half, we've had the opportunity to focus our resources on what I call the software, and that is of the cardiac department. And by that I mean the people delivering those services. So this is really the nursing team mostly. Our first venture was for a CCU nurse called Erica Bradley, who has completed her postgrad diploma in cardiology, so we funded that. Currently we have 3 CCU nurses, Juvie Pabellin, Bethany Walmsley, and Colette Nelson, who are about to take a really vital course, and it's offered by, and I'm going to read this, Society for Cardiological Science and Technology. And it's a diploma in ECG interpretation. So they're all CCU nurses who, obviously, if you can't understand what an ECG looks like and what it means, it's kind of important on the CCU ward. So it's vital training and for their role in treating and testing patients on CCU. And that brings us to our current joint project, which is collaboration again with Manx Care. And this was a problem was brought to us that had to do with the heart failure nurse program. And I had to actually look up what the heart failure nurse program actually means. And it's heart failure services designed for those people who have impaired heart function, which results in symptoms of breathlessness and fluid retention. And those are the people who they're in that middle ground of something's wrong, but they're not bad enough to be in CCU, but they're in that sort of zone where if they don't look after the problem that they have, that's going to escalate to something that eventually will be more serious for them, but will also is more costly in terms of Manx Care. So you kind of want to look after those people so they don't get sicker. These people have heart conditions that require mostly management, and in order that they don't escalate into something more serious. The service is run by just one heart failure nurse, who is Marie Webster. And she started in this role, I think it was about 2013. Yeah, 2013. And she had a caseload of about 60 patients. Very manageable caseload. She was easily able to see new patients quickly and existing patients often. However, in the intervening years, her caseload has grown and post-COVID exploded. And the last time I spoke to her, she said she had well over 300 on her books, currently with a waiting time of clearly more than 2 weeks. So it is a service that was stretched thin. The quality care guidelines for this service suggest no more than 100 to 125 patients and the waitlist time of 2 weeks. And it meant that this vital service is dependent on only one person to run it, delivering it, and obviously stretched very thin, which I'm sure is not a scenario you're not unfamiliar with, because resources are stretched everywhere. So this was the problem that Marie brought to us, and she brought a potential solution. And that solution was paying for the further education of a second heart failure nurse, and who's a younger colleague called Grace O'Hagan. And Grace is already a nurse on CCU. She's undertaken extra training on her own, and she's deeply committed to coronary care. She's a real rising star. And so last year we agreed to pay for Grace to enroll in the postgraduate course in heart failure management in clinical practice, and that's at Keele University. This was already full at the time, and apparently full for them means 5 people. So it's a very selective course and a very intensive course. So Grace was happy to wait, which in effect was actually a good thing, because as you can imagine, this course has a heavy emphasis on clinical learning. So you must be training and learning in situ. So it meant that Grace would need to be shadowing Marie, and Marie would be her mentor, throughout the heart failure clinics and working under her throughout the coursework. They soon realized that this was going to be, with staffing issues and stretched as they were, there was a good chance that Grace could be seconded back onto the ward at any time and not be able to complete her clinical training. And so then they came up with a second idea. And in order to really complete these studies fully, Grace or anyone needed to be actually working in the heart failure service. So they proposed that a second position to be created to allow Grace to both deliver service and learn at the same time. Almost like an apprenticeship model, really. So you've got somebody working as a second heart failure nurse, learning at the same time, and by the end of the year, should be fully qualified. And of course, there is no second position, so we found a solution in collaboration with you and Manx Care. Manx Heart Foundation, we take on the financial risk for educating and training the second nurse, and paying for the second position for a year. So basically, we're funding a second heart failure nurse, which, and I believe at the first 6 months she's at grade level
Band 6.
Band 6, and then going up to Band 7 when she's fully qualified, and we're paying for all of that. And at the end of the year, if we can prove the business model that it works and it's needed and we've brought the wait list down and patients are getting better care, then Manx Care will then take on on the second role as the quote new norm. So there will be two people running the service rather than just one. And that also would mean that patients could be seen more quickly and existing patients could be seen more often. It also means that the two nurses running it, one can be seeing mostly inpatients, most patients in hospital, and one can be more in the community, which is also part of the guidelines, the UK guidelines, that most of the heart failure nurses in the UK see one or the other. They don't do both. Obviously, we're in a different sort of situation here being in Ireland, but hopefully that we can, this will work and we can only lead to better patient outcomes. So we're now 1 month into the program. This began in January, and Grace has provided me with an incredibly comprehensive update. She loves shadowing Marie. She is fully invested in what she's doing, apart from some technical hiccups with computers and equipment and things like that. They're up and fully running, and she starts the actual course on Thursday, I believe, for actual coursework on Thursday, and it's amazing. It is absolutely amazing, and it showed us that this is a model that we can perhaps replicate in other departments, not other departments because we're cardiology obviously, but other roles. So there may be other roles that we're creating an apprenticeship model might help educate and better educate others. Other charities might be able to take on the same thing in different departments, but it's a really, so we're sort of, I don't want to say we're leading the way, but we are leading the way in doing this. So anyway, we're incredibly excited about the venture, all the education. It means we're investing in people rather than stuff. The stuff is good, but it's stuff, and people are much more important. So if you have any questions, I'm happy to take, or we're happy to take any questions.
Thank you.
Thanks.
Thank you so much. That's really... it's
Talk
really...
too fast.
Pardon me?
I talk too fast.
No, it's really good to hear that sort of partnership approach between the service and what you're able to support. Does anybody have any comments or questions? Paul?
Well, I mean, just to echo the massive thanks for the support of the
Thank you.
of the charity, which I think we would really struggle to deliver great care without your help. So I want to just put on record our thanks for that.
Thank you.
And echo what the chair has just said about the partnership being so important going forward. And you know, you're touching on a number of things that I feel very passionate about. Not least the highest standards of care that we can provide, but also thinking about the future and how we build resilience into our workforce models so that we can function as and when people retire or move on with their careers. And for a long time, I think Manx Care's functioned well, but with multiple single points of failure, which is, you know, a single individual. If they weren't available, everything would stop. So I'm very encouraged by the fact that we're thinking in the same way about how we make ourselves much more resilient to function safely and well as demand increases. So thank you.
I think it's a really important point that when you have I never really thought of it as a single point of failure, but one person, anything happens and you're stuffed. I mean, she would go off sick and then suddenly that wait list. So this hopefully will build some resiliency
Absolutely.
in the system.
Yeah, hugely excited about it. Thank you.
Thank you.
Nigel?
KC,
Yeah.
we know each other obviously
We
very
do
well,
indeed.
so making that available, it was a lovely story to hear, and thank you very much indeed. And I would like to say that this is a story that's very close to my heart, because, literally no pun intended, because I lost my father to a massive heart attack when he was 42 and I was 18, which changed our family's life considerably. So it's great to hear the change of approach from way back in the 70s, which when this occurred, you know, to now, and the education and awareness that you're promoting, I think is absolutely brilliant.
Thank you.
And I think the other thing that touches us is that you're encouraging the growing of our own, in that you're actually encouraging people to educate up and upscale in terms of their skills on the island, which I think is terrific, rather than us trying to bring people in all the time.
Yeah.
We're actually encouraging people to get educated here, so thank you for that.
Thank you.
Thank you. Charlie? Tim?
Hello.
Mary?
Hi. Good morning. I run a charity in the UK. I'm the Chief Executive of Smart Recovery
Oh, wow.
UK. I work in addiction recovery, so I really appreciate the position that you come from as a charity and the decisions that you have to make to invest your precious money, a lot of which is donated by the public, and fundraising is a really crucial and important part of what you do, but it's also really important there's that line of sight from the people who are donating to what they actually see. So, I really commend you on kind of diversifying how you're investing your money between equipment and people. So that's really nice to see. The other thing to say is, when you're when you're part of a charity, is everyone expects everything for free, because charities it's free at the point of care. There is this kind of assumption that everything that you provide is for free, but there's a cost to running a charity. The one I run costs about £42,000 a month to run, in infrastructure and staffing and so on and so forth. So the fact that you've invested, but the fact that you are proving that the business model works to the board, that you're reducing waiting times, improving the education of your staff is really important. So I commend you on that. You've not just come here and asked for extra investment. You're actually spending a whole year or more providing the information that we need to help support you. So again, fantastic on that. And it's lovely to see you working in consort with the rest of the kind of healthcare system. And importantly, what you're touching on is the prevention agenda, which is really, really important for us going forward. We have to move away from firefighting all the time and helping people to live healthier and better lives. So I'll be really excited and interested to see longer term how what you're putting in place prevents further catastrophe, as Nigel has just explained, down the road. And the quality of life that what you're doing will bring to those people. But also in the future, if you're seen to be having this big impact on people's lives and reducing the waiting list, it will drive up your fundraising efforts in future, that the public will join you on that mission. So I'm very keen to see how this pans out. I think it does need some kind of profiling in the public domain so that people know exactly where you're spending your money. And then also further down the line about how you're improving quality of life.
And getting the feedback from the structure of how those waiting times are coming down, what the actual tangible difference is. Because obviously you need that in order to say, yes, we're going to put forth this money for the position next year. But we need that to know that, yes, this is a good investment. And the public need to know it because, like you say, the more that they see what we can do, the more money
the more
comes our way, the more money that comes your way.
Yeah, absolutely. And a heart failure patient becomes inactive, and that comes with a whole other raft of issues as well.
Exactly. And there's fear.
Yeah.
This suddenly came to me at about 5 this morning. Wait equals worry. So when people wait and have to wait a long time, they suddenly worry more. And then that has this huge snowball effect to affect all kinds of other parts of their lives, where if they can get seen quickly and they know they can seen quickly, then the worry goes away. You're really ill, you're not really ill, it's bad, it's not bad, whatever it is, you have an answer and you can go forward.
Yeah.
I guess my overarching feedback is thank you for investing to improve things in the future, but bringing us with you on that journey and not just coming to us for money, but actually proving that what you've put in place, the business model, is or will work.
Thank you.
And then we can work with you in future to build that up.
Thank you.
Thank you.
Thank you. Thank you, Charlie. Tim?
Like others, really applaud the partnership working, and I think that's more that Manx Care can do to work in partnership with the voluntary sector and charities. So really applaud that. Also really applaud the apprenticeship type model and the access to training. So thank you very much. But my question is for our chief executive and team really, is just to gain the assurance that we will be able to pick up the funding for these posts, and we will be able to integrate them, because there's nothing worse than projects coming to an end and the voluntary sector funding projects, and you have all these little tails of projects hanging on which just come to an end. So was really wanting to, from the executive side, get the reassurance that this will be these posts will be incorporated and will become funded and mainstreamed, and what the impact on that is given our funding position.
Yeah, so when we had these discussions, I mean, we know we have very extensive cardiology weights, so we knew it was a specialty where we need a clear and coherent plan, and that's where we're doing a lot of partnership work, certainly with Liverpool Heart and Chest, which Oliver is leading around that memorandum of understanding, to make sure we have a comprehensive cardiology pathway. As far as we can, we know this is a really important specialty, and so the commitment is there to put the recurrent funding into this post. We do anticipate it will be hugely successful. We've got a very dedicated individual with great supervision and support and leadership from the rest of the team. So there is no reason to suggest it won't be hugely successful. And as an organisation, as far as we possibly can, we have committed to that ongoing funding once the non-recurrent funding ceases. So absolutely yes.
That's brilliant. Thank you very much.
Thank you. Miriam.
Yeah, like my colleagues, I just want to echo my thanks for the work that you do with us, because I think these partnership approaches are just absolutely key to growing our own workforce. And I'm really hugely excited that you're modelling things on the apprenticeship model, because I think that is a gap for us currently, and I think that we can use you as a kind of case study best practice in terms of the best way to grow our own on the Isle of Man. So thank you.
Thank you. Yeah.
Thanks, Miriam. Oliver.
Yes, I mean, I'd just like to echo the thank you, really. As a GP, I think it's really important that we're looking at prevention of deterioration, keeping people from coming to that crisis point and needing those machines, you know, and like you say, the people are probably the most important part of it. And in my work as a GP, I see the difference that a good clinical nurse specialist can make, and it's a big one, and I think this is a really important thing, so thank you very much.
It's good to hear.
Thank you.
Could I just add something? Sorry.
Please do.
We used to have this model of funding machinery, and there was just no awareness in the public of what our charity was doing, because these were machines in the background doing specific services. And that was really based on the large legacy that the charity received. Now, you can't rely on a charitable management on legacies, so you've got to change your fundraising activities to match expectation. So we've changed our model to be able to do that. So what I want to just reassure is that if we cooperate together as a team, so Manx Care Management, ourselves and Grace and Marie, if we can meet at least 2 or 3 times independently just to see how that model's going, because we have enough funds in our account to be able to continue with Grace if we have to. We would prefer to then start to enrich another specialist. But what we want to be able to do is start this momentum going. Then we have a much more achievable fundraising target, because we can achieve, we don't need as much to deliver a massive machine or whatever that might be. So it's that kind of cooperation that we need, and what we're looking to and develop in the charity. We're also merging with the Manx Heart Support Group, because they've sort of, I think they've got to an age and an energy level where they just can't maintain themselves. So they have a membership group, and we have a membership group, and we obviously plan to grow our membership. And Casey and I've met with the cardiology department in the rehab area. So that's what we're going to be doing after every rehab session is meeting new heart meeting people who have had recent heart issues and bringing them along and helping with that education as well. So it's quite a broader concept of not only medical care, but also supporting those that have just had those episodes.
Thank you.
Putting the heart in the heart. And getting the heart back.
Yeah.
I think I've exhausted every heart. Things I could.
Well, thank you very much. And I know that from what Teresa said about the approach to this post, that partnership working and those regular check-ins, Richard, are really important. So I'm certain that those will continue. Just thank you so much, and thank you for being willing to change the way that you support the delivery of care, because I think, you know, Charlie runs a charity. I've been involved in charities for many years, and sometimes it's the death knell of a charity that they won't be prepared to change and change their model or change their funding stream. So thank you very much for being willing to do that and for making, you know, such a difference to the lives of people on the Isle of Man, which after all is what we're all here to do. So thank you so much, and thank you for coming to speak to the board this morning. We really do appreciate it.
Thank you
very much.
Thank you.
You are very free to stay, but you're also very free to go. So thank you very much indeed. Thank you.
Sorry, I just ruptured my Achilles tendon, so it's
Oh,
a bit easier for me
ouch.
to
Take your time,
take
please.
my time and not be too fidgety.
Thank you
here.
everyone for having us.
And please do pass our feedback on to your team and
Yeah, we
colleagues.
will, yeah.
Thank you.
Oh, absolutely.
Sorry, I'm not-
Yeah, you're fine.
Oh, thank you, bye-bye.
Thank you.
Thank you. Have a good day.
So I'll move us on now to our board assurance framework and our deep dive into risk 7 around information governance. And Jackie, I think this is for you.
Yeah, thank you. So we've clearly information governance has been a really important area of focus for us since we began, and I think I'm pleased to report that the actual level of risk posed to the organisation is definitely reduced over time. However, I think there's still some rather large gaps in our assurance and our control that we need to remain mindful of and keep absolute sight on, because we've had massive improvements in terms of our relationship with the Information Commissioner.
Yes.
And we've managed to avoid the penalty fee imposed by the previous Data Commissioner by managing to respond to all of his requirements. But what we're facing is two things. One, there's just an inexorable growth in the number of FOI requests, data subject access requests. So just the volume of work being requested of us as an organisation is continually rising at a very fast rate. And our team at the moment are not quite large enough to deal with that. So we are seeing a slight deterioration in our responsiveness to those requests. And if that continues, then our ability to consistently meet our requirements in that arena is going to be impacted. The other thing that's seriously impeding our ability to be assured in terms of our data is around the Manx care record and the length of time that particular initiative is taking. We continue to have multiple systems holding multiple data accessed by multiple people, and the risks contained therein are huge. And until we have that resolution, that risk is going to continue for us. And I know that we've had our clinicians have recently gotten together and written a formal letter to the government expressing their concern about the speed or otherwise of the delivery of the Manx care record. We have had some good news since we last met as a board, in that funding has been agreed for that initial business case development, but that's just the first stage. It's taken us quite a long time to get to that. So I think for us operationally, I think we've made great strides forward in terms of doing everything we can within the current constraints that we operate in, to do the best we can, but we're still constrained A, by resource, and B, by the underlying Manx care record system and our inability to move that forward as quickly as we'd like.
Thank you, Jackie. Welcome, Gregor.
Hello.
Is there anything you want to add?
I'm happy to go through the assurances if the board want that, but I presume that you've got this document that you've read, so
Yeah.
probably don't need to go through it line by line. To be honest, I think Jackie's hit the nail on the head with the Manx Care record. Most of our data is so spread across so many different systems, a lot of which are not linked together, a lot of which are not even linked to the NHS spine to ensure validation or accuracy. And that is what's causing the biggest problem, not just in the delivery of safe care, but also in data breaches, not being able to share information appropriately or safely. And until that data is all joined up in one solution, the frequency of data breaches is likely to remain high.
The just a question from me about the increase in FOIs and what's the other thing called?
DSARs.
Thank you. How much has that risen, and do we know why?
I'm not sure of the exact figures, but it's rising in double digits in terms of percentage demand increase.
Okay.
It's not limited to Manx Care. It's being experienced all across government. All government departments are experiencing that same level of demand in FOIs and DSARs.
Okay. So is there a conversation across government about that?
I think there's a balance to be struck, because obviously, you know, we have an obligation and a responsibility and a desire to make sure that people have free access and easy access to their information and their data. However, I think there's probably more that can be done in the space of making certain data more easily available and accessible. So rather than personal data, we get lots of freedom of information requests that actually probably relate to information that's already in the public domain.
Yeah.
So it's a little bit about, I think, making sure that as much information as we can have as possible is in the public domain, so we can signpost people to information rather than spending lots of time answering specific questions.
Yes, indeed.
And then we can focus on stuff that's individual,
Yeah.
that needs individual attention.
Yeah, I think that's really important, and I think, you know, the board has always been very clear, you know, demonstrated by this meeting being held in public, that we will try and put as much information into the public domain as we can. So,
Yeah.
Okay, any questions, Wendy?
Thank you. Jackie, just a quick question about the governance around the Manx Care record and the multiple different places that data's coming from. Are we clear what we're responsible for and what others are responsible for? And is that clear to people who are then asked questions about it?
Yes, so the Manx Care record is a transformation, it's being led by the transformation team, and Gregor, we as Manx Care are clients and stakeholders in that and are very heavily involved in that. But I think the actual resource and capacity around driving that piece forward rests with the transformation team. Is that correct, Gregor?
Yeah, that's correct.
Yeah.
If I could just point out as well that part of the specification for the Manx Care record will include service level access to their own data. And it's right and proper that individuals should have access to their own health and care data. And that in itself should help to reduce the burden of DSAR requests coming in for individual requests for individual care information, because they'll have it accessible to them anyway.
I think though one thing to note is that one of the areas that's of particular can be particularly challenging for the IG, the Information Governance team, in responding to DSARs, is less about health records and more about records in terms of social care. There's an enormous amount of work tends to have to go on in there in terms of redaction, because very often these are situations that involve multiple people, so that they spend an inordinate amount of time taking that information and making sure that it's in answering one person's question.
Yes.
They don't inadvertently divulge information of another family member or so
Put
on.
somebody at risk.
That's very, very complex, and
Yeah.
particularly we have some quite complex cases, and we've had some challenges in that area.
Thank you, Oliver.
Thank you. I think this is really important that this is sort of highlighted. I think we mustn't forget that the situation that we have with information governance and the concerns that exist, perhaps rightly or throughout the organisation, about making sure that we get information governance right. It's not just an issue for the status quo now. It is also a brake on innovation, and it is a brake on a drag on developing services, doing new things, working innovatively.
I'd agree with you there, Oliver. There have been instances where the trying to do cross-cutting work has been impeded by our ability to or inability to safely share data with one another. Yeah, absolutely agree.
And I know if Katie was here, she would say that, you know, it's just gone on too long.
Yeah.
And it's, you know, it's taking far too long. So whilst it's good news that the funding has come for that initial piece of work, we're still way, way, way behind where we should be. So.
It predates Max Care.
Yeah.
Pardon me?
It predates Max Care.
Yes, indeed.
That's how long it's gone.
Yeah.
I think though it's important to, so whilst there is remaining a risk to us, I think it's important for us to reassure people that we are doing everything we can within the current constraints to protect their data, and data is better protected now
Yes.
than it was 2 or 3 years ago. So we are improving in that space, because I'm conscious people will be worried.
Yeah.
We are definitely improving in that space, and the level of control that we have over that stuff has definitely improved. I think the reason we're raising this to the board level is that the barriers that we're facing now are strategic, and much bigger than simply doing things better or new processes and policies.
Nigel and then Teresa.
Yeah, thanks, Sarah. Excuse me. I sit on Digital and Informatics Committee, and I would just echo the points made by Gregor and indeed Jackie that we've been pushing very, very hard to get this moving for over a year and a half now, and it's a constant subject of discussion, and we feel very strongly about it. But I think the knock-on effect is very real, not only in terms of not having a joined-up system and having data in different places, but also in the inefficiencies that we're now putting sticking plasters over. So we're looking at a digital solution, not just the computerization of what's already there. It's very, very different, as we all know. So it's clearly very important that we keep on pressing this case very hard, because it is now, bringing itself to bear in terms of inefficiencies, of the fact that we're having to spend money on an increasing service, putting sticking plaster, to use an analogy, over it, rather than actually sorting out the root cause.
Yeah.
So it's an imperative that we keep that pressure up. But again, it's the old Spider-Man phrase, power without responsibility. And we have responsibility but without the power. And that's a dangerous combination. And it's something we have to keep on seeking to address.
Thank you. Teresa.
Yeah, I mean, it's important for our system and for Manx Care and all the services that we provide. But I would just want to sort of highlight quite strongly that it's really important for those strategic partnerships that we rely on in terms of our patient pathways with the UK. So the UK have a very strong push on the electronic patient record, and I think over 90% of trusts now have an electronic patient record. So only a small percentage of trusts in the UK don't have that, and there's a real focus on those that haven't. And obviously we're in that space, so it's critical for our pathways with the UK that we don't get even further behind than what we are, because we are creating those stronger partnerships and collaborations with England in order to make sure we have really good patient pathways.
Yeah.
So it's a real strategic issue for us as well, with our joint working with the UK and our plans as a board for increasing that going forward.
Yeah. Thank you. Thank you. Sorry.
I'll just make one final comment,
Of
Sarah.
course.
I think it's important to note at this point to take a moment to appreciate the enormous amount of hard work that's gone in with Gregor and his team on the Manx Care record side, and on the Jenny and the information governance team. They've worked extraordinarily hard to get us to the position that we're in today, and I think we should formally note our thanks and appreciation of that work that they've done.
Yes,
because it's largely invisible.
Yeah.
Very pleased to do that, and thank you, Gregor, for coming, and please do pass on our thanks to your colleagues. Thank you. Thank you very much.
Thank you.
So, come to my report, which is in your pack. This is my final board meeting in public as the interim chair. Wendy will take over next month, which I'm delighted about. I just want to add my thanks to all my non-executive and executive colleagues for their support and challenge, and enabling me to take on a role that I never really wanted to do in very sad circumstances. I'm absolutely delighted that on Thursday we will give an award in honour of Andrew Foster. I think that is incredibly fitting to a man who championed staff and their commitment to delivering health and social care so centrally in everything that he did. So I'm really pleased about that. I also wanted to say a huge thank you to the Tynwald members who very generously gave us so much time yesterday to talk through probably the issue that has been the most difficult over the last 3 years and will continue to be the most difficult, which is the funding of health and social care on the island. And I think we would not have been able to have those very honest conversations yesterday without the huge amount of work that's been undertaken by people around this board table and those that have gone before us in setting the groundwork for us to be able to have very robust conversations with politicians about the enormous responsibility that we have, which is spending public money to deliver health and social care to the people of this island. So I'm willing to take any questions that anybody has for me. If not, I will pass on to Teresa. Kate.
Really just to commend you on a fabulous job. I've obviously not been on the board that long, but it's been great to have your sort of mentorship and leadership of the board. So just huge thanks from the non-execs.
Marina.
I'd like to thank you for being so supportive, for being so kind, but mostly for being so compassionate in everything that you've done. And I wish you the very best. Thank you so much.
I obviously now can't speak.
I have a question for you, Sarah. What on earth are you going to do with that?
I'm going to remain as vice chair. Thank you.
Thank you. So I will take you through just a couple of highlights of the Chief Exec report. As always, we try and capture a lot of the great work that is going on in the organisation through the Horizon scan. It is disseminated, it is shared with our media partners, because I think it really does capture some great work going across the organisation. I just would like to pull out one thing and put a shout out for the island hosting a women's health strategy, a Four Nations Women's Health Strategy event on the 19th of April. So we're hosting this with colleagues from England, Scotland, Wales and Northern Ireland coming, and Kate has kindly lent her support for that event too. I think that's a great piece of work led by the Integrated Women, Children's and Family Service. Coming to the main part of my report, I just want to acknowledge the publication of the COVID review on the 8th of January. The executive team of Manx Care will be going through all of the 31 recommendations in detail, and through both the social care arm and the health arm, considering all of those recommendations with some assurance route through our Quality, Safety and Engagement Committee. So we'll be bringing back our action plan in response to the COVID review through the board in due course. A central response by the Cabinet Office has also been established. I also wanted just to outline our apologies to the public on the delays that we've had commencing service from following us taking over the Regent Dental Service. This was due to an IT issue. It meant we weren't able to allocate appointments, but I'm pleased to say that we've actually started calling people for appointments from this week. Thank you to our teams who have spent a huge amount of time preparing for this. We have managed to recruit dentists and associated staff for the practice, and they will be onboarded within the next couple of months. I also wanted just to outline that we have appointed an executive director for social care, integrated health and safeguarding, who is Dr. Tim O'Neill, who will join us from April the 15th. Tim is a very experienced executive director who has led both children and adult social care services in a number of areas of the UK. He will relocate to the island with his family, and I'd like to place on record my thanks for David for covering as an interim for the last 12 months. And there will be a period of handover, won't there, of about 3 or 4 weeks, with between David and Tim, just to help Tim to settle in. I'd like to endorse the Safeguarding Annual Report for 22-23, which has been published in late December. We're an active member of the Safeguarding Board, and I think, again, it charts some solid delivery of the Safeguarding Board over that year, certainly focusing on self-neglect following the thematic review, and also working in partnership and some new partnerships around the multi-agency safeguarding hub, and a real strong focus on assurance and scrutiny. So again, some great work by the Safeguarding Board. Also would like to endorse the Hospice Isle of Man Measured Ambition strategy, which has been recently published, a 3-year strategy. Over the last 12 months, we've always had a great working relationship with Hospice Isle of Man, but I think we have seen a real strengthening in that partnership over the last 12 months with the new Chief Executive. We have much more transparency of data, some real innovation around some opportunities for workforce, and a real commitment from Hospice Isle of Man around protecting clinical services and being a really strong partner. I think there's a lot of things that we learn from each other, and I would suggest that partnership is really strong and we really value it. Would just like to announce our annual public meeting for 2023 will be held on the 2nd of July, and we've chosen to move it up to the Mountain View Innovation Centre up in Ramsey. We've had a really good response to our annual public meetings over the last 2 years. Great public attendance. Staff have really enjoyed showcasing the services in Manx Care, but it does feel like the space we have used on this site, we've slightly outgrown it and we do need more space. So that innovation centre up in the north of the island just gives us extra space to do that. Finally, I'd just like to speak about the engagement events that took place last week. So I had the great honour of spending 4 days out of the office with our new head of comms and engagement, Kevin Lawless, and visiting, I think, about 27 services across 4 days. It was the most wonderful 4 days, I have to say, meeting lots of teams, seeing the great work that they do, hearing about the innovations that they've put in place. A number of these teams sort of have met on an annual basis, and I can absolutely see the improvement in culture, the improvement in access. Some of these teams have eliminated their waiting lists and done really positive, innovative things to keep services going. The speech and language team, who had been under huge pressure with high levels of vacancies and a very long waiting list, are now at full establishment, and they have eliminated their waiting list, and I think that is to be commended. The renal team, who are currently based up at Ramsey, because there's some work being done, some estates work being done to the renal service here. They have relocated in full up to Ramsey for a temporary period. They have absolutely focused on their patients. They are running renal services up until 11 p.m. at night, completely rescheduling everything to be able to deliver the programmes of renal care for the patients and the dialysis. So a huge thank you to Jerry, who's the charge nurse, and Dr. Khalil. But I have to say, I was just humbled by the staff, the welcome I received, the work that I see happening, and it made me immensely proud. And I am absolutely going to commit to spending more time out of the office and seeing what we do. It was like therapy, I have to say. And just, I always put in the risks that we are managing across the organisation. I chair the Risk Management Committee, which meets monthly. We have a mixture of deep dives into various different areas of the organisation, as well as looking at those extreme risks, and those are detailed there for transparency. Many focus around our financial management and some of the pressures that we have, some of our workforce pressures coming back to sustainability and potential single points of failure where we have only a very small number of clinicians in a service. and access and waiting times. But I'll stop there. I'm happy to take any questions on my report. Thank you.
Any questions or comments for Teresa?
Sarah, may I?
Yes,
Yeah.
sorry, Mike.
Teresa, I'm really interested in your visits out to the teams, you know, can we be assured that our sort of imperatives to start to help and improve culture in the organisation is really beginning to show fruit and bear fruit now?
It definitely is. I think, you know, we offered I didn't pick these teams.
Right.
We put a communication out, and these teams offered themselves, so they welcomed us. You know, I can compare conversations that I had 3 years ago when teams were probably not quite as open, not quite willing to share what was going well, but equally what wasn't going well. But I see that transparency now. I see that willingness to share, that pride in the work they are doing, that sense of ownership that they feel to Manx Care. And generally, everyone feels much more positive. And I think it is very difficult to quantify that. But how they engage and their willingness to talk about what they do, the pride they have in their work, I think is a reflection of that positive culture. And, you know, the commitment, the openness, the visibility. They're not frightened to talk to me or any of the execs. You know, they're quite happy to tell us how it is, good and bad. And I think that is a really positive sign when they can just tell it as it is. And, you know, I thoroughly enjoyed it.
Well done, because I think this is really good news, and I think we should be really pleased. I mean, it doesn't change overnight, and
No.
there will be many more hills to climb, I'm sure. But, you know, it's really good news to hear that, and very positive, because to me that's the beginnings of what I would call a psychological contract, not just a physical contract, and I think that's great news indeed. Thank you.
Now, what I will do is write all this up for the exec, because I think there's some things that we should recognise are some very positive achievements. There are some areas where we still need to address things, and some real challenges, and then there are some asks and things that we would want to consider through the business case review group process, or indeed speak to some of our partners and charities on, because some of these things are actually quite small things that would make a huge difference to services. But there is a long list from the services. But, yeah.
I think taking the opportunity to go out to staff is so important. And I have an allergic reaction when managers say I have an open door policy, because I think it's very easy to forget when you are a manager or a leader how difficult it is to walk into your manager's office and you know, to leave your ward or your office and to make that journey, and for people to ask you why are you going and where are you going and what are you discussing. And so I think it is so important, Teresa, for you and all executive colleagues, and indeed when the non-execs are here, for us to be able to go and meet staff is central to what we do. It's not a nice to have, it's part of our responsibility. So thank you for doing that, and for Kevin for setting those up. I think we're all looking forward to the staff awards on Thursday, and an opportunity for us to celebrate a small part of what staff are doing. And I wanted to put on the record our enormous thanks to those organisations and companies that have funded the awards, and so we're able to deliver those with no cost to the people of the Isle of Man. And Oliver can pay testament to the fact that the news is out that these awards are happening, because when he went to hire his DJ and couldn't quite remember the date, they absolutely knew the date in the hire shop. So there's clearly great excitement, as there should be across the island. And finally, Teresa, if I may, just to echo what you've said to David. David, thank you so much for what you've done over the last 12 months, for being willing to come back, and to lend your enormous experience and expertise into an area that, you know, the board is still very concerned about in terms of staffing levels and staff morale, but I think you've done an exceptional job in the time that you've been here with us, and thank you so much for that.
Thank you for the opportunity. It's been a privilege. Absolutely.
You're not going yet?
No. 3 months to go. Yeah. Not that I'm counting, but 3 months to go.
Thank you. Anybody else have any questions or comments? Charlie?
Not to take up too much time. I'm just looking at the risk register, Jackie. I just wondered if you could pop some helpful context around the 2 new financial risks that you've placed on there: failure to develop adequate financial management systems and failure to secure funding for safe, effective services. I mean, the second one, I'm surprised that's on as a new risk, because I've heard a lot about that over the last year. Just some helpful context, just because I think the paper that could be taken out of context and worry a few people. So
Thanks, Charlie. Happy to.
Thank you.
So the reason, so most of we obviously have financial sustainability as one of our BAF risks.
Yes.
And sitting in our DATIX, which is our system we use to manage our risks, there are various risks that have a financial impact, and then there are various financial risks.
Okay.
But I felt it was important to try and start to crystallise what I think are the 2 single biggest threats to our ability as an organisation, or to function properly in a financial sense. The first is obviously funding, and we've all talked about funding. And I think, you know, we can implement all sorts of controls and effective financial management, and we can manage what we have as efficiently as possible.
Mm-hmm.
But if it's not enough to deliver what we need to do, then it remains a risk in of itself. And I felt it was important to really get that clear and out there and very clearly articulated. So it's not just individual care groups have got financial pressures, there's actually a strategic risk there for us.
Okay.
The other one around financial controls is that's the other side of your sustainability, is that you manage what money you have effectively. And we're still growing in terms of our maturity as an organisation around our controls around our finances. So just going back to the culture point, we can see a massive increase in the level of engagement, understanding and knowledge of the finances that we see at all levels now throughout the organisation. However, we do still have gaps in some of our financial controls particularly around our purchasing, because we're limited to using the Treasury's own accounting system, which doesn't have a purchase to pay function, which is, you know, you do it electronically. We still sign purchase orders intricately. And there are things like that remain a risk to us, some of which are difficult for us to control because we require other support to do that, and others of which we need to just continue to improve our own controls and housekeeping. In response to that one, the finance team themselves have expanded over the last year and introduced additional capacity to address that around reporting, so people have even more information and visibility and as close to real-time data as we can get it, and also an increased focus on compliance and controls to make sure that we've just got all of our housekeeping I's dotted and T's crossed.
Thank you. That narrative's been really helpful.
Thanks, Charlie.
Thanks, Charlie. Tim?
I'd just like to refer to the appendix in Teresa's report, the Safeguarding Board's annual report, and just like to commend that and say, again, just to reiterate how important safeguarding is to this organisation and to all the partner organisations, and that hackneyed phrase is that safeguarding is everybody's business, but also how important it is to the population of the islands as well, in terms of safeguarding. I just wonder next year whether we could ask the chair to come and present the report herself to this board, because I think that might give it a bit more impact. Thank you.
Excellent idea. Yeah. Any other comments or questions for Teresa and her report? Thank you. So I move on now to the committee chair's exception reports. So Jackie, in Katie's absence, I think you're going to speak to the the D&I.
Yeah, so I think the main point of escalation from the D&I committee remains the risk around the Manx care record, and we've already discussed that. The second area where we have a concern is around the age and condition of our IT estate. We've got many systems which are reaching end of life, going out of support, and they represent a real risk to us in terms of our ability to sustain those systems. I think over time we've We've eked them out over time in the hope that the Manx, or the expectation that the Manx Care record would not replace those systems, but those systems will be able to work with the Manx Care record. So now what we're finding is that we're having to, as Nigel has mentioned earlier, provide sticking plasters to some of those systems, and extending life and support for some of those systems in the circumstances that we're in, with a level of uncertainty, the age that they're at, where providers really just want to walk away from some of them, means it's going to cause us a lot of expense in order to sustain those systems. And again, it's not that these systems will go away, it's that we need to make sure that these systems are working effectively, so when we have the Manx Care record, they can feed into it. So that's going to be the more immediate risk to us in this hiatus between where we are now and the Manx Care record. So they're the two big issues for us from a D&I perspective.
Thank you. Any comments or questions for Jackie? Okay, so on behalf of the People Committee, I think there are three issues to escalate to the board. One is our inability as an organisation to agree a 3-year funding settlement for our staff. We are unable to do that. We have no influence over 37% of our staff who sit under the PSC employment contracts, where their level of pay is set by the government. And that is clearly a risk to us in terms of recruitment and retention. At this point, I know that there are conversations going on at government level, but I, as the chair of the People Committee, are not able to assure the board that we have a long-term view on our pay for staff. An Operations Performance Board has been established by the Cabinet Office, who are looking at the performance of government departments. There's been a set of metrics that's been set out, into which we have had very limited input. So the committee is concerned about us being judged by a set of standards over which we have not had any say. And finally, the HSCC members across all the committees have resigned, and that leaves us in a situation where we don't have that independent oversight into any of our committees, and we won't have that report coming up to the board. And I think that's an issue of concern for us, particularly to the point, Jackie, that you raised earlier about transparency and openness. It's been something that we have really welcomed into those standing committees and now have lost. There are other issues for assurance, and I particularly would like to pull out there just one of those, which is the work that Miriam has been leading to really ensure that the People Dashboard is giving us some set of data that we can at least be confident in. We're not there yet, but it is not through want of trying. And Miriam, thank you so much for the hard work that you've been putting into that, particularly because we have a shared service around human resources, and I know there's an enormous amount of negotiation that's had to go on to get us where we are. But we are beginning to see some shoots of hope, can I say? And it's really important because without that data, we aren't able to provide assurance to the board and indeed to the Department for Health and Social Care about where our people are and what people are doing. So it is really important that we continue to make headway in that area. Miriam or I would be very happy to take any questions. Is there anything you want to add, Miriam?
Just to say that in terms of the people systems, part of the issue with the data is very similar to what was shared around the Manx Care record. Obviously not with the same impacts, but the fact that there are multiple people systems used around government and multiple inputting, adds to the IG risk that has already been laid out, but secondly, it makes reporting very, very challenging, because it's coming from different perspectives, different systems and different approaches. So I think there'll be an element of, in terms of the data that the board can see, of those things that are really basic should be relatively straightforward with that negotiation and investigation that we're doing. But there are going to be elements that are going to be a little bit more challenging to get in the very short term. So it's just to make the board aware of that.
Thank you. Okay, so moving on, Tim, if I may, to you for quality, safety and engagement.
Thank you, Chair. Two areas we wanted to pull out. One was the ongoing concern around staffing challenges, particularly in medical areas and theatres, and the priority that managers have in making sure that those areas remain safe and have a safe level of staffing. And that's something which I know the Director of Nursing and his team are on top of and are pursuing, and ensuring that those service areas remain safe, but it is a pressure for the organisation. And then the other area I wanted to highlight, and I know again that Oliver Radcliffe is on top of this, and this is a long-term issue, but is the deficiencies within the emergency department, particularly around mental health facilities. And I know there are plans in place, and it's a long-term piece of planning, and I know that the ED in itself is fit for purpose in terms of what it was built for and now what it's having to manage. So those were the two areas that I wanted to highlight, and happy to take any questions, Chair.
Any questions for Tim? Nope. Thank you very much. Nigel, coming to you for FP&C.
Yeah, thank you, Sarah. Well, I'll do both if I may, because both FP&C and audit met last week, and so there were two areas in FP&C we wanted to escalate to the board. Clearly, colleagues are very aware of the tension and the difficulty that exists around financing at the moment, and the cost base that we face. This has been examined very rigorously at FP&C, and Jackie will talk more about that under the section on finances later on in the meeting. And indeed, thank you, Mr. Mann. I know you've raised some questions around this subject too, and we'll cover those off later. But I think, I think there was a very useful meeting yesterday led by the department with members of Tynwald and Council of Ministers, and I think government are alert to the difficulties and tensions that we face in financing and defining the kind of service we want to have going forward. But this is a supertanker, and if you spin the wheel now, it may turn in a year's time. And, but I think I was very encouraged by the meeting we had yesterday, and I was encouraged by the understanding that we were able to convey to members of government, and I think they get the issue. We now have to solve it. The other point I'd like to raise is that a lot of work has been done by the contracts management team in creating a robust framework for how we buy in third-party services. And this is across the piece. And it started out as a huge compliance exercise many years ago, only 3, but it seems like a long time, many years ago. But that has now matured into I think, a very mature and robust system for how we contract and how we commission third-party services, and I commend it to you. In audit, 2 areas that I would like to mention are such that I believe the audit committee is maturing well, and I think is performing its function better than ever. We have a great relationship with the internal audit department. There is much mutual respect, and they can not only gain assurance as a government audit department, but also help us gain assurance from areas where change has been brought about and where we want to validate that change and essentially see it. So I was very pleased about that. And 2 areas in particular, the area of clinical audits, which is progressing and being very well led. There's a lot of work to do. But people are doing it, and I'm assured that where there are gaps, people are beginning to see those gaps and work on clinical audits very well, and we've been ably assisted by the Medical Director, Marina, on that, and thank you, Marina, for your help and continuing help in that area. The other point I would like to raise with audit is that coming up shortly is going to be an audit of the relationship between the Manx Care Board and the Department of Health and Social Care. around the governance surrounding the mandate processes and budgeting processes. And I think this is going to be a very interesting piece of work indeed, because it will examine and look at the way in which we as a board work with the department. We have views on that, but it would be interesting to see how audit either accept or decline our views. Those are the two areas I'd like to raise. Thank you.
Thank you. Any comments or questions for Nigel? No. Tim, did you want to talk about the IPs? Yes.
Thank you.
Thank you.
So from the Integrated Care Partnership, I wanted to highlight for the board particular issues and concerns raised by members of the third sector. This is a partnership committee, so we have members of the third sector who attend and are really helpful and insightful in the discussions which we have, but particularly concerns around the confusion around who commissions what on the island in terms of whether that's the DHSC, other parts of government, or Manx Care, and indeed the funding mechanisms, whether they're grants or contracts for the third sector. So not within Manx Care's gift, but I think it was important to raise here for the board to hear that there is that level of confusion and concern within the third sector, who we obviously, having heard from members this morning, we want to work in partnership with, and how we can better explore that and assist our partners in the third sector in terms of their organisations and their roles. That was the main issue I wanted to highlight.
Thank you. Teresa.
Yeah, and I think it's a valid concern and something we should respond to. We have talked and we have started the work, but I think a very explicit commissioning framework for how we commission for all aspects of the business that Manx Care has a contractual relationship with all our partners is required, and a commissioning strategy, because I do think we've inherited quite a mixed piece, different levels of contractual appliance, different arrangements in place, and I would agree that probably hasn't helped have a clear position from either side. And I do think we want to be open and transparent, but equally as we start to respond to some of the learning from Ofsted, from CQC, how we respond to things like the day services review that we have already undertaken, it's really, really important we have a transparent commissioning framework where we can, before we start those pieces of work, be really, really explicit with all the providers in our system who we work with, what our intentions are, our strategic goals, and how we will approach doing business with them. You know, I think it's really important we have that before we start doing these big pieces of work, so we're clear on our expectations.
I think that's really helpful, and that obviously is within the gift of Manx Care. So if we can be clear, I think that would be very helpful.
And we've started doing that work, and it has been coming through FP&C, hasn't it? But I think that's probably where we just need to understand where that piece of work is at and how we can get it. I know it has come through the mandate discussions as well. So the DHSC have been clear. They've also wanted to see a clear commissioning framework from us.
Thank you.
Thank you, Tim. Okay, so we are 45 minutes ahead of schedule. But I think, would people appreciate a comfort break now? Yeah. Yes. So if we take 15 minutes and come back at past. Thank you. So, Teresa, we have in our pack an assessment of Manx Care from the department. I'm sure colleagues have read the report, but if you wouldn't mind just highlighting any issues to us, that would be great.
Yeah, no, thank you. This is our formal letter of assessment from the Department of Health and Social Care for the year 2022-23. So it feels quite old now, but it is their formal assessment. So it needs to come to the board. I think it was an ambitious mandate, if I start by saying that, and I think what we've done subsequent mandates is try and work on a much closer and realistic alignment. But that said, I think there has been good progress, and I think it's a fair reflection. The things that I probably feel I should point out is, despite the overspend position, which was disappointing, £10 million worth of savings was achieved in that year. I think in terms of the areas for development, and board members will recall that a large part of the transformation programme was formally paused in July 2022. So whilst some elements of the programme continued, some very critical work streams, largely linked around care pathways and development, was paused because the finances wouldn't allow that work to continue, both preparing sort of that care pathway work, but also recognising the recurrent impact on Manx Care's finances should that work progress. So at the time there was a decision made that there was little point in progressing that work when ultimately that couldn't come to fruition because the financial position wouldn't allow. Obviously the transformation programme is in the process of transferring formally from the Cabinet Office and the Department of Health and Social Care. We will have the opportunity to understand what programmes of work will be restarted, and we will be bringing that to the board in due course. But I think it is important to reflect that we've had 18 months of a number of programmes linked to the transformation programme being formally paused, and that is obviously reflected in the overall assessment of the mandate. I think the other point which is pertinent to highlight, because it has been raised a number of times through various different reports, is just where we are deficient in terms of some of our workforce planning issues, our workforce modelling data, our ability to assure ourselves on our mandatory training, because this is all provided through a shared service. So quite rightly, the department has identified that as a weakness through our mandate. We've obviously recognised that as a significant weakness through our board and our assurance committees, and I think we need to come back to having a clear and concerted plan as to how we address some of that. Certainly not being able to give strong assurance on levels of mandatory training was highlighted by the CQC. And whilst we have worked hard to validate that information, we still do not have accurate reporting available to those assurance committees. I think it's also worth noting that through our subgroups and the People Committee, we have attempted to validate what is the vacancy rate for the organisation. And I think we can say with a level of certainty that it isn't the 22% that is routinely quoted through the people analytics data that comes to the People Committee. The validation exercise that has been done indicates, I would suggest, it's between 13 and 15%. I think what is difficult to assess is what was that starting position. But I think that level of funded vacancy rate of around 13 to 15% is much more in line with what our sort of comparators in the UK are experiencing. And we'll need to do further work on that, but I think that is an encouraging position. I'm happy to take any comments or questions, but as I say, this is reflective of the year 22-23.
Any comments or questions? Tim and then Jackie.
Just a couple of areas. I see in the areas for development highlighted around metrics and data being available and notes and improvement. I'm assuming and grateful for your comment whether that is also due to the lack of the electronic record and how we're able to produce timely data and accurate data which can be benchmarked when we don't have the Manx Care record. Also, just in terms of the HR and people development strands which are in here again, just reflecting on how we do that with the capacity within a shared service, and how important perhaps it is for us to make sure that we have capacity within the organisation, which is able to take that all the way through.
Yeah.
So those are just really the two areas which I was just reflecting on.
I would agree, and we know we have seen improvements in both the data quality and the generation of our integrated performance report. But actually, I would still suggest we are at a relatively low level of maturity. And one of the things that has been picked up and we scrutinise regularly is just that we haven't got clean data. And so we have invested in a validation team to look at our waiting list so we can accurately report on the waiting list position. We have developed an access policy across the organisation to help better govern our waiting times, but there is still an awful lot of work to do. And Oliver might want to describe the sort of process that is involved in generating the IPR and how that isn't able to be done in a timely way as to have real live data, which is ideally what we would want as an organisation for our decision making. And I think we've talked extensively about this as a board, about the level of support we need around our human resources function, our workforce function, and all that sits with it. And we absolutely recognise there is a very, very important role for shared services to assist in this area. We recognise it is cost effective and efficient, but equally we also, as an organisation which employs 3,000 staff and is running an organisation of around £347 million, that's some additional dedicated workforce resource is required for us to be able to plan accurately going forward and to do some of this work. I think as we move other agendas forward, we are recognising that we have made as an organisation over the last 3 years much less progress in this area than we have in every other area of our business. And I think it's something the board needs to perhaps consider in much more detail through perhaps a development session. Because I think it does need a multi-pronged approach and a number of solutions, because I think we should set the ambition that 2024 should be our year of really making sure our workforce planning, our future strategies around the workforce, our cultural improvement, and all the data which is required to do that well is given due care and attention.
Thank you very much, Chair.
Oliver.
I think Jackie was...
Oh, sorry,
Want to
Jackie.
talk about the IPR then?
Well, I was just going to respond to what Tim's first point, because I was going to mention it under the IPR section, but I'll mention it now just in relation to the waiting times data. It's true that we've, as a health system, Manx Care and its predecessor organisation has never published accurate waiting time data. We are now in the position to do that, and we're planning to publish accurate waiting time data in the next couple of weeks. That's following a successful validation of the outpatient waiting list, which has seen just over 23,000 patients on the outpatient waiting list, either waiting for a first appointment or in the process of, within treatment, with just over 4,000 people being removed from the waiting list, which is great. And some day case validation also happened, which meant that we're now in a position to publish that publicly, which, as I say, is the first time that the system has ever been able to do that. What we can't do at the moment, because we don't have the resources to do it, is to say how long an entire person's treatment pathway will be. We can only say, this is the average time you'll be waiting for an outpatient appointment. This is the average time you'll be waiting for a day case or an inpatient admission. What we haven't been able to do yet, and it's within our aspiration within the recovery and restoration business case for phase 3, is to put in that recurrent infrastructure so that we can start to measure what RTT, referral to treatment times, that all waiting times are measured in the UK. So somebody knows that if they are referred to orthopaedics for, say, a hip problem, that they would be waiting a certain amount of time from that referral to the treatment. So that's something that we are aspiring to put in place, but a really good work that the validation team has done over the last 12 months to get certainly the outpatient elements of the waiting list fully validated.
Tim.
I don't want to take us somewhere which is not helpful, but you said 23,000 people.
Mm-hmm.
Is that, again, benchmarking? Is that what one would expect for a population size that we have? That's getting on for 25% of the population.
That's the total of people who are within an outpatient pathway. So it's not people who are waiting, but there are some people in there who are waiting. But it also means that people who may have been seen by a consultant who is awaiting a follow-up appointment.
But would we expect 25% of the population to be generally accessing hospital services?
No, I would suggest that's quite high.
Yeah.
I would suggest that we've got a lot of individuals who are in follow-up for quite a considerable amount of time, and we do have still quite long waits for new outpatients. I think we need to focus on some of those initiatives around patient-initiated follow-up. We really need to be able to put our waiting list into being really clear about what are long-term surveillance, and they're separate from our usual follow-ups, but have a scrutiny and performance management of our follow-up rates, because I think we do have too many patients within hospital services. It links back to our joint working with primary care, the ability to move some patients out into the community under shared care. It's definitely part of that programme of work that we have under primary care at scale. Obviously, we need to make sure we're appropriately resourcing that transfer, but I would suggest there are an awful lot of people on hospital-based waiting lists who should be having their care primarily delivered in the community, but we must make sure that community infrastructure is there to support that transfer.
Thank you, it's helpful. Thank you.
Jackie, and then Kate, and then Oliver.
Thanks, Sarah. So just picking up on that data point, absolutely, and it's obvious that when you've got poor data, you can't plan properly, and that has the obvious impact on your financials as well, in terms of where you place your resources. I think what's becoming obvious as we go through this process, and we've mentioned it a few times, is that there are large areas of delivery for us where we are being held to account and expecting ourselves, and others are expecting us to deliver, where our level of control over the pace and tempo of some of those changes is limited. So we're a key stakeholder in some of these, we're a client in some of these, but we don't control them. And some of our shared services fall into that, some of the work around transformation. There's various areas where we hold the risk, but we don't necessarily hold the control, and I think we need to recognise that in many areas where we're underperforming, or be considered to be underperforming, we're grappling with some of those control issues. I think the other piece is around the mandate is we do still, and it was particularly obvious with the mandate year that this is referencing, but there is a timing issue between when our funding is approved and when our mandate is agreed. So at the point at which the mandate that this refers to was agreed, there were very many aspirations in there that had funding implications, and that came about after our funding envelope for 22-23 had been determined. And whilst those two deadlines are coming closer together, we are still being presented with a mandate with aspirations in it that we would all share, but that is being done after the funding envelope has been agreed for the year. And that funding envelope has been agreed without consideration of these. So basically, we've put in a financial plan based on what we know. We get a financial envelope off of that. But then after all that happens, we get the mandate, which then says we would like you to do these things, and that's after we have an opportunity to secure the funding.
Yeah.
So again, I think that hampers us in our ability to respond as much as we would like to some of these objectives. And I know that the department understands this and has worked with us in terms of what their expectations are, but it's really important going forward that we have mandated objectives agreed in advance of seeking funding for the year in which they apply.
Yeah, understood. Kate.
Thank you, Sarah. Oliver, just a few kind of points from me. So I'm assuming sort of when you helicopter this up, the data point is very much linked to the digital transformation, the electronic care record, all of that kind of thing, because, you know, someone that's run hospitals for 27 years, I don't know how you cannot do those things, because they're routine tools, aren't they? But presumably when you publish the initial data that you've got, the 23,000, Oliver, that's going to be by specialty, is it?
Mm-hmm.
And I'm assuming that some of the reason that figure feels quite instinctively quite high is that people have multiple comorbidities, don't they? So they might in fact be on several waiting lists. So it's probably not people, it's referrals, isn't it? Yes, exactly. Okay, thank you. I just wanted to clarify that. Thank you.
Thank you. Oliver.
I think this kind of builds on what you've just said, actually. The more you think about how these things can be measured, at first glance it must be quite straightforward, you know, percentage of people, how many people are waiting. But actually, the more you think about it, the more you drill down and the more you understand how the Manx Care is such a necessarily complicated organisation. I mean, it's an awful lot of work, really, to produce good data and getting meaningful data out of it. And I think it would be really helpful when these things are published to get some real detail about how those the headline numbers were arrived at. What's the numerator? What's the denominator?
Yeah.
What are the inclusion criteria? What are the exclusion criteria? Is this all routes of referral, or only via PIC? That sort of thing I think would be really helpful because that's the sort of data that we need, apart from anything else, to move stuff into the community, and that would be really helpful.
Yeah. Well, I think, you know, the base that we started at when Manx Care was formed, you know, there wasn't any definitions of how that data was extracted previously, and so a lot of the first kind of 18 months, 2 years of the process has been defining what an outpatient weight is, what an inpatient weight is, how it's extracted from the system, making sure that number is correct and it isn't impacted or kind of changed, or, you know, is the number that we're extracting is correct, and so you know, we're now in a position where the majority of that is done. In the next month or so, we'll have the full planned care data set now validated from a data definitions point of view and also from a validation point of view. But, you know, given that I know 18 months ago we didn't have a performance team at all, the BI team was only about 5 people. For such a big organisation, I think we've come a long way, but there's still a huge amount of work to do. I agree, in terms of being able to provide that data in a much more granular level. So, you know, specialty level we're going to provide, consultant level I think we would want to do, and also, you know, being a bit more interactive with the actual data that we present. So it's not just a table of data. You know, people who are accessing it can go and drill down a bit further. So I agree.
Thank you. Any other questions or comments? No. So we've sort of started talking about the integrated performance report, haven't we?
Yeah.
in some of your responses there, Oliver. But who wants to start talking to the IPR?
Shall I carry on?
Why not? Thank you.
So I was just going to cover a couple of things that are going well. I was going to talk about cancer and then a couple of areas where we are challenged. So we're continuing to see decreases month on month in both the day case and the inpatient waiting list, which is really good to see. The majority of the recovery and restoration phase 2 activity is now completed, but we are continuing to see reductions, which is testament to the fact that R&R has left us with quite a legacy of improved efficiency. So our ability to undertake more orthopaedic procedures on each list, length of stay being reduced, the numbers of cataracts that we're doing on one list increasing from 4 to 12 per list, etc. So whilst the recovery and restoration activity is largely completed, we've just got one weekend left of general surgery to do, and then that's all of it done. We are continuing to see those reductions despite us being back into business as usual. And also, for the first time, I've mentioned in the IPR, we're starting to see reductions in the number of patients that are waiting a first outpatient appointment. So they've been reducing for the last 2 months, which is a combination of the validation work that I talked about, but also some improved efficiency, particularly within orthopaedics. Now that we've moved the orthopaedic service back onto this site, there is actually physically more space for them to run clinics. We're doing some waiting list work within ENT and dermatology as well, which has seen a considerable reduction in the waiting list for those 2 specialties, particularly ENT, which has got quite a backlog. From an ambulance response time, we're continuing to see better than standard response times from categories 2 to 5. We're continuing to see a longer than standard response time for category 1. So category 1 response time, which is the most time critical of all responses from an ambulance point of view, being 7 minutes, and we are averaging at the moment just over 9 minutes, 9 minutes and 2 seconds. We're managing to maintain that despite the increases in ambulance demand that we're seeing associated with the winter period. I'll talk about cancer. So we're seeing a fairly stable position in terms of cancer. From a faster diagnostic standard, which is our primary access standard for cancer at the moment, we're seeing that 66% of people are receiving their cancer diagnosis within 28 days of referral, which is less than the 75% standard. That's because we're continuing. We were seeing some issues, particularly within the breast service, within December due to staffing issues. But I've recently given an update around the breast situation, which, although we are losing our substantive breast surgeon and our substantive breast radiologist, we do have locum cover arrangements in place for the next 6 months, which will see the capacity of that service. It is, however, worth just mentioning that whilst the standard, our performance against the 28-day standard is less than the target, currently the median performance of the 28-day standard, so essentially people that are on the cancer pathway, are median number of people are receiving their cancer diagnosis within 16 days. Which is quite significantly under the 28 days, and that's because the majority of our diagnostic pathways are in-house. We're also seeing an improvement in the 62-day standard as well, so that's 57%, which again has been improving over the last 3 months. We're putting that down to changes in our cancer tracking system. So each cancer site, each cancer service has its own service level, what we call a PTL meeting, patient tracking list meeting. So each cancer specialty has its own weekly meeting tracking all of those patients through the pathway, rather than just a single weekly meeting looking at all of those patients on the cancer pathway. So we're finding that it's a lot more granular management of patients on the pathways. From an ED point of view, we've seen a deterioration in our 4-hour performance. So 68% of patients who attended ED were seen and discharged or seen and admitted within 4 hours. That is principally down to the increase in demand that we're seeing through winter. As Tim mentioned in his escalation from QSE, one of the issues that we do find is because the ED has only got 16 treatment spaces, so 16 cubicles, when we are in a situation, which we have been quite a number of times over the last month or two, where there's over 50 patients in ED, we do really struggle to be able to see all of those patients within 4 hours. You know, it's just physically impossible to see 50 patients within 4 hours through 16 treatment spaces. And one of the things that we are going to be kicking off in the next month is a large capital estates programme to redevelop that quadrant of the site to not only increase ED capacity but also to build in some of the more contemporaneous services and systems that urgent care have, particularly in the UK, so same-day emergency care and clinical decisions unit. And then finally, just around the dental waiting list, it was in the media last week just around the size of the dental waiting list. I just wanted to provide a bit more context around our current provision for NHS dentistry. So in total, there are just under 42,000 people on the island have an NHS dentist, and the current budget for that is 4.2 million. We don't have any eligibility criteria, as people are probably aware. So in theory, the waiting list for NHS dentists could go up to 43,000. There is literally no limit of the number of people who could choose to request an NHS dentist. The NHS within the UK have an eligibility criteria which is quite strict, and I have done a bit of work to just compare ourselves to the UK in terms of what our NHS dentistry provision would be if we were choosing to use the NHS eligibility criteria, and that's would be 18,000 people. So less than half of the people who currently have an NHS dentist in the here on Ireland would have one if we applied the same eligibility criteria. I don't think we're in a situation where we are looking to introduce eligibility criteria here, but obviously it's something that we need to consider, given that Jackie will come on to talk about finances in a bit, but I don't think we're in a position as a health system to put any more money into dentistry. So I think we do need to consider with the DHSC how we look to manage the allocation of NHS dentists. But it's a really tricky problem and not something that we as an organisation have the ability to do, because all of the NHS dentistry regulations are under the remit of the DHSC. A piece of progress anyway, some progress to note, that we've agreed with the DHSC to set up a working group to look at both the dental and the optical contracts, to look at where there is the ability to strengthen the current contracts that we have with particularly dental providers, look at what the regulations are, whether there is any tweaks that we can make to the regulations, whether it's regarding eligibility, whether it's regarding charging. There's quite a few levers that we can pull to improve the situation. Now, the other thing to just mention is that we have made a decision that all of the contract management of dental and optical will be transferring over from the primary care team to the contracting team, and we're just in the process of recruiting for a contracts manager for that. That will mean that the contracts management piece will be alongside all the other contracts. So there will be everyone will be in a formal contractual monitoring arrangement, which previously has been undertaken by primary care, and we think that separation of contract management and almost relationship management will strengthen that whole process. But clearly the provision of NHS dental care is a huge concern, both across the population and also from a political point of view. And I think the next 12 months, I think we need to concentrate on just improving the contractual and the regulatory framework around dentistry to see whether we can improve access. As Teresa mentioned earlier, we have seen a bit of a hiccup in relation to us taking over Hillside, but I'm glad to report that the provision will be returning to normal from this week, and we're looking to prioritise patients. So we're looking to prioritise children and also people that haven't had a checkup for a long period of time, and that's with a view to recovering and making sure that everyone's had their checkup and is up to date with the necessary treatment within the next 6 months. So that's it from the IPR. Thank you.
Thank you. Any questions or comments? Kate and then Teresa.
Just one very quick question and for clarification, and then one comment. In the just on dentistry initially, so 42% of the Manx population have access to an NHS dentist. Do we know what proportion of the remaining of the population have private dentistry, or I guess we wouldn't know that, would we?
We don't. It's about 50% have an NHS dentist, so 42,000 people out of a population of 85,000, so just under 50%. We're not sure what the data is for the rest. We do provide a community dental service, which is primarily for emergency treatment. So if somebody hasn't got an NHS dentist, can't afford a private dentist, they still have access to treatment from an emergency point of view through community dental services.
Thank you.
Obviously, it's not ideal because we'd rather be preventing dental problems than curing kind of in crisis, but
at least they have access to that, and that takes obviously unregistered patients.
Yes,
that was going to be my follow-up. And then just the comment to say on the IPR more widely under maternity, the smoking. It's good to see that although your smoking at booking rate is quite high, by the time delivery comes, it's dipped down to about 6%, which is kind of pretty much in line, isn't it? So whatever you're doing, keep doing it.
Yeah, I think we have really strong smoking prevention support within our community midwifery and antenatal clinics. So that's bearing fruit from the data.
Brilliant.
Thank you, Teresa, and then Charlie.
It's just on the dental, we have escalated those statistics from UK eligibility up to the department, so they can at least consider that in the context of where they would wish to prioritise. I just want to sort of ask in terms of, and it might be something that Paul would want to contribute, in terms of, we know we have a smaller ED than what we would like, and we're not going to resolve that immediately, but what assurances can we give around harm being assessed to patients who have an extended wait within the emergency department? We know the evidence from the Royal College of Emergency Medicine around 6 hours being critical and 12 hours being critical. Are we able to provide any assurances on that, or is it a piece of work we may wish to undertake and route through the Quality, Safety and Engagement Committee about harm from long waits in ED?
I think it's something that we should be looking into, definitely. I think we are continuing to see 12-hour waits within ED. We're not, as we've said a number of times through this board, we always place patients on a hospital bed after 4 hours if they're to be admitted. The majority of patients are in a single room, so they're not within a large treatment area, and we don't place patients on the corridor. So from a privacy and dignity point of view, we maintain that, and given the current situation in the UK around very extended trolley waits on corridors on a natural trolley rather than a bed, we perform significantly better. But from a harm point of view, because ED isn't a ward, it's not staffed like a ward. We hold a lot more patients than a ward does. ED has the ability to, unlike a ward, which is always set, the maximum is the number of beds it has. Within ED, there's almost no maximum, and as I mentioned earlier, that we have been seeing upwards of 50 patients within ED relatively regularly now that we're in winter pressures. I think we do need to have a think about how we monitor that in terms of harm.
I don't have any data on the assurance that you require, Teresa, so I can't really comment on that, but I think the point I would make about it, when harm occurs, it's too late, in my opinion. It's inevitable that while we continue to stack people in ED overnight with shortages of registered nurses, we're going to struggle to deliver a high standard of care. And the longer people are in ED, the harder it is, the slower their progress and the slower their recovery when they eventually get into the system. And it's not the same with things like meals. They don't get hot meals served, and they don't get their medicines in the same way that they would otherwise do if they were on a normal ward. So I think your question is a good one, but I think we instead of measuring harm, I think we should look at what are we prepared to do as an organisation to make sure ED is staffed sufficiently to meet the needs of the people who we are holding in that area for extended periods of time, and work back from that. Because if we can do that, then I think we can ask the question, are people getting the intentional rounding that is the assurance you're after? We can't do intentional rounding if we don't have the staff.
Can I suggest we revisit our escalation policies and our full capacity protocol then for ED, because I think that we do have one of those, and we probably need to make sure it works to enable those escalations to happen when we are at those points where we have seen high volumes coming through. And actually sometimes the overcrowding is linked to downstream flow. It's not pure demand into ED. It is a lack of flow across the system. And that links to the work which the executive are taking forward on golden patients and making sure our discharge planning, the other end is optimal. But I would suggest that the Quality, Safety and Engagement Committee might want to take some assurances on how we are managing an overcrowded ED and flow through the hospital.
Thank you. Charlie, did you want to?
It was just briefly on the dental piece, if I may. I appreciate you not wishing to adopt NHS eligibility criteria. I don't think that would go down particularly well. But what that means is you are going to have more individuals with a dentist than you may be able to cope with. So there's some other things that you might like to explore. So some of the ways that dentistry manages supply and demand in the UK is they switch on and off the ability to register new dental patients. So it will be, your local dentist is now accepting registrations or not, so you can switch that on and off. If you don't access your dentist within about 2 years, you're kicked off the books, so to speak. So you then do not have one, and you then have to find another one and re-register later on. So there's a way of clearing out people that are registered but don't actually use and engage, and that also helps to manage supply and demand as well. And there are always appointments held back, if you like, for private patients. If you want to pay in the UK for a dentist, I could see one tomorrow. I can't even get into a dentist at the moment, kind of thing, in the UK. And funnily enough, one of my main dentists has actually can't find any trace of me, and I've been there and had treatment. So there are some issues over in the UK. It's been in the news this morning, people queuing around the block for a new dental practice that is open. So none of this is unfamiliar, but there are kind of ways and means by which, if you don't adopt the eligibility, you can manage supply, demand, flow, so on and so forth.
Yeah, we do. The dental allocations is managed centrally. So that's how and we do the cleanse, as you've mentioned. So
it's called a cleanse.
Yeah,
yes. It's probably a more diplomatic way of putting it.
Yeah. So we do what we can. As I mentioned, there is a lot of work that we do need to do around the contract, particularly our ability to drive performance by our contractors. So, for example, this year we are estimating just over 280,000 worth of clawbacks, as we call it, so where the contract hasn't been fulfilled. And that's which, when we've got such a high waiting list, that seems criminal. But one of the issues that we've got around our contract is that we aren't able to monitor and drive that performance.
In real time, so to speak.
Exactly. Yeah. So that's why we need both the support of the DHSC and or the support of the Attorney General's chambers for us to be able to completely rewrite that contract.
And I think we've had some of those conversations, haven't we, with the Minister about needing to have a better grip on the contracts, and there is support there for that to happen.
Definitely.
So, Oliver and then Wendy.
I'd just like to, just a small point, I think if we're talking about sort of the dentists fulfilling their contracts as independent providers, I think we need to be careful about how we sort of reflect on how that performance is described, and it might be that I take your point. Criminal is when you say criminal, it's very it's not right, and perhaps something needs to be. But I think we just need to be careful about how we think about how our independent contractors are working, and be mindful of the pressures that I'm sure our dental colleagues are under. I think I'd like to just pick up on talking about that the ED situation and 50 patients, and you were talking about like downstream stuff, but it is also about upstream as well, isn't it, and preventing people getting there in the first place. I think very often ED waiting times are the most visible marker of a system that needs realignment, and I think we must always remember that it's a whole systems approach that we have to take, which is certainly what we're doing.
It is. I think we have a great opportunity with some of the work that we're doing in the Emergency Services Joint Control Room, See, Treat and Leave, and the transformation that has been invested in the out-of-hospital space to really make a difference and to avoid a number of those patients coming to the ED by putting in the diversionary pathways. I think I would like to see a stronger focus on that piece of work, and a number of those pathways embedded and working effectively, because I think we have a great opportunity to significantly reduce the conveyance rate to ED, and I'm not sure we're maximising that opportunity at the moment. So again, I think I'd like to pick that up through the operational committees, and have some further discussions about how we can maximise that. There's a huge opportunity and a significant amount of investment going into those. But we have I would suggest we have at least 30-40% conveyance rate beyond what we should be accepting as a system.
Yeah. Can I just come back to what Oliver mentioned at his first point? Yeah, I agree. I think what I meant was not a kind of criticism against our dental contractors. I know that they're working in a very challenged system in terms of both dental recruitment of dentists, and we do have across the board we pay less for a dental unit of dental activity compared to the UK.
Yeah.
So we are not as competitive as the UK. So I know that a lot of our dental providers really struggle to balance the books as independent businesses, in terms of what they're getting from us to reflect the payment for NHS dentistry versus the recruitment difficulties that most dentists have around recruiting dentists. So yeah, absolutely.
Thank you, Wendy.
Thank you. Just to go back to Teresa's point strategically about workforce and workforce analysis and planning. Dental services, very large amounts of them can be delivered by people who are not dentists, so dental nurses, dental practitioners. And that is quite a difficult conversation to have with dentists sometimes.
Yep.
But there is a report in England called Advancing Dental Care that provided a workforce analytic tool which might be quite useful. And it may be a way of growing your own. Dental nurse to dental practitioner is a really good career move. And it may well be a way of getting some joint private practice. So people who are working as dental nurses in a private clinic may wish to develop their skills as part of an NHS offer. So I would counsel that strategically we probably need to, as well as looking at contracts and cleaning up the data on the waiting list, I think we need to look long term at where would we get a workforce that would, for the sum of money offered per patient, provide a level of care that is not necessarily requiring a dental degree.
Yeah, there's us taking over the Hillside practice has meant that we are going to be looking at skill mix and employing a dental therapist as part of that, as almost a kind of proof of concept, really, because us taking over Hillside means that it won't be in a kind of UDA payment type environment, because it's our service. So we are going to do exactly what we've said, and yeah, it will be an interesting kind of, as I say, proof of concept to see what can be provided by other contractors.
Thank you. Nigel.
Thanks, Sarah. Yeah, clearly the whole area of dentistry is difficult, and I get that, I understand that, and I don't want to appear like a broken record, but I do want crisis and opportunity often go hand in hand, and when we engage with our dental colleagues to discuss how we solve this problem, I would just encourage us to be aspirational. And, you know, I don't want to appear like a broken record, but we do often refer to what's going on in the UK. And there are good reasons for that, and there's good data coming out of the UK. But can we please, at a time of elegant change, shoot the lights out? Let's aspire to be better than the UK. We are different. We are an island. We are a village on a rock in the Irish Sea. And I think we can do better than the UK if we apply our minds and we get goodwill behind it.
Yep.
That kind of funding.
Thank you. Who would like to go next? Please do.
I think by and large, as you can see in the report, it's been a pretty good December, which I think reflects the quality of the winter planning and the preparation that went into particularly the Christmas period, which I think went exceptionally well, much better than I think many of us anticipated. As a consequence of that, we've been able to maintain a really good outturn on our quality metrics. Which are self-evident in the paper. The thing I perhaps want to talk about is we did see a bit of a drop-off in antimicrobial stewardship in December, but
Yeah. That is a test.
Is it? Yeah.
Yes.
That's Tuesday today.
There we go.
So
That
it
was
sounded
First out the door.
the timing of sounding the alarm. So our performance dropped to about 70-something% in December, which was unexpected. However, it has since recovered significantly in January to 90%, which is the highest it has ever been since we started working on that agenda. So I think what we witnessed in December was an unexpected, unanticipated blip in performance. We're back on track, which is great stuff. And hugely encouraged by the fact that those people who give us their feedback on friends and family testing, 9 out of 10 say their care was very good or good, and that's held up right the way through the last few months, which is hugely encouraging. That says that our staff are handling people with dignity and respect and compassion, and that people appreciate that when we do that for them, which is great.
Excellent. Any comments or questions? Jackie?
Paul, just on the friends and family test, could you talk to us about the numbers of people who are responding to those? So the 90% is a fantastic score. But how many people of our total number of people we see in a day, for example, are actually responding to that?
Let me see if I can get the data. I'm not sure I know the exact number for you, Jackie. I can come back to you with that figure, what the response rate is.
Would we say it's in the low or high?
I have to come back to you with a number.
Yeah, it'd be interesting to know that.
Yeah.
Any other questions or comments for Paul? David?
Thank you, Chair. If I could just highlight a number of points from each of the service areas, really. So mental health continue to have good performance around length of stay in our bed-based services. So they're either on target or overachieving, and that's been fairly consistent for a number of months now, which is good. People seen within the timescales, all around 100%. Again, consistent over the last few months and good performance. And our response times generally above target, about 85%. And the target 75%.
Is that another form of test? It must be.
It must be.
I'm not moving. Excellent.
Adult social work, re-referral rates, has been quite a bit of work done on that over the last several months now, looking at how we triage people coming through the service, how we close cases, how the protocols around that, and that's starting to show some really good results now. So our re-referral rates have reduced considerably in some parts. So that's good work and good focus on that. An area of concern for us remains assessment timescales within 28 days. We struggle to do that. We have done for some time, mainly around LD, and we know that those cases are much more complex, often involving multidisciplinary input, multi-agency input. And we have a conversation now with our BI team and with the department around looking at those timescales and those targets and whether or not they are realistic. So the suggestion is that we look at 6 weeks for LD rather than 4 weeks, just allowing for that extra time and the complex nature of those cases. So that's conversations that are happening now, so we're hopeful that that will be agreed at some point. Safeguarding, you'll see for the first time we've included some safeguarding metrics in there. It's work in progress. We haven't quite got that right yet in terms of what we're measuring, but already it's telling us that we've got a 30% increase in the number of safeguarding alerts around adults. And there's a business case coming to the business case review group tomorrow looking at some additional capacity to help cope with that.
Bless you.
So we're seeing an increase in that. Children, just to explain, you'll see one of the metrics there that's reduced down at 0%. But that's initial child protection conferences held on time. And to put that in context, there were 3 conferences in that period. And the reason for the missing the timescales was that families were not available within that timescale. So just to explain that's unusual performance. Usually it's obviously much better than that, but that's a kind of one-off. And just a general comment, as per the conversations earlier, I think we struggle with the data and our data confidence around some of this. We still have far too many manual systems where people are capturing data on spreadsheets, which is very time-consuming and often delays in terms of the accuracy of those that information coming through. But we're working with the BI team to unpick some of that, and we are progressing with it. So hence some of the improvements that we've seen have been down to data cleansing, data capture, and understanding and unpicking some of those data issues that are there.
Thank you.
Happy to take questions.
Any questions or comments for David?
Would it be possible to come back, if there are no questions for David, to come back on Jackie's question?
Please, yes.
Jackie, on the page 215 of our bundle, covers the detail on the response rate. There's 943 people responded in December. 860 rated their carers very good or good. And it does fluctuate, as you can see in the graph there. Sometimes we have higher response rates than that. It's hard for me to say whether that is low or high. I think what I would say is it's very encouraging that we are getting feedback.
Absolutely.
And you know, I think we should take whatever feedback we get. There's a piece in the report about the efforts people go to remind people of the friends and family test and how they can use it, and they can use their mobile devices, and there's a postal service as well. So it does require a bit of an effort on the part of our volunteer services just to move that on, but I think that's not bad. 1,000 responses or thereabouts is pretty good.
No, if I may, I completely agree, Paul, and you know that kind of qualitative data is very, very important to us in terms of understanding how our patients and service users are experiencing what we do. So 90% is amazing and it's fantastic. What we now need to, and I think we're consistently reaching levels like that with our survey feedback. I think now what we need to do is make sure that it's 90% of 50% of our people, not 90% of 1% of our people. Now, I think the response rates, the 900 in a month, are probably more than one, but I think now that we've stabilised our response rates at good or very good is now making sure that we're sure that that's a reasonable enough cohort of our patients, that we're reaching everybody and not just a small few. And I know you're absolutely right about the efforts. I know that a lot of effort goes into encouraging people to fill those out, so thank you.
Kate.
I was just going to make a very similar point to Jackie, which is it would be nice to know how many patients you saw in that time. So if you've got 900 responses, but you saw 250,000 patients, then it's not great, is it? So you just need to know the denominator to know what your response rate was, and then you can just apply a bit of sort of intuition to the figures, can't you? But knowing that the denominator would be really helpful if we could add that to the report.
Needs to know the total activity, which is every single contact, inpatient, outpatient, phone call.
It's not as simple as it sounds.
Caboodle, that would be quite
But it's also about where those friends and family test results are coming from. Because if the majority of them are coming from inpatients in Nobles, then that would be the comparator, wouldn't it? Nige.
I think it's great news, and I'm loving the engagement story. I think there's a danger that at a time of tension and on the journey that we've been on, that we could run the risk of being too self-congratulatory. And so I'd apply the same kind of criteria to the complaints mechanism, because the complaints mechanism is and would be a very useful measure of how we're going. And I wondered if we had any granularity or any detail around the MCAL's service. We know that it's accessed very well. We know that they're dealing more and more efficiently, I think, with the queries they're receiving. But are there any thematics emerging from those complaints and from those queries within MCAL's? And what are we learning from them?
There certainly are. I don't have the detail in front of me, but they go through the QSE periodically. We do that thematic analysis, the underlying trends. People have, from memory, people experience problems with waiting. They experience problems with accessing some services and the stress of that, appointment times, and the way they're handled by some of our staff. Sometimes positive, sometimes not positive. They're the main issues, really.
Thank you.
Thank you. Any other comments or questions? Marina, do you have anything to add?
Just to go on about mortality, that we continue to do very well, 99%. So we keep going up. And level 2, I know there was a question at the last public board. We have started doing those. 2 have been completed. There's 49 outstanding. Unfortunately, we had to cancel the mortality review group meeting last week because of the bed situation. We needed to move the doctor to Ramsey, but we will have the meeting in March, and then we'll be able to provide data of how many of those 49 have been completed. So the important thing is that we're heading in the right direction.
Thank you. Any comments or questions? Good. Thank you very much. I'll move us on now to you, Teresa, for an update on pay negotiations.
Yeah, thank you. So since the last board meeting, we have at last and finally concluded the pay negotiations for 22-23. So those were concluded and signed off in early December. So moving to this year's pay negotiations, as we've previously outlined, a third of our staff, just over a third of our staff are employed under the PSC terms and conditions. PSC offered 6% earlier on in the year and settled in the summer. So a third of our staff are resolved in terms of their pay negotiations for this financial year. Once we had clarity over the financial position of the organisation in sort of October, November time, we were able to put a pay offer for this year to our medical and dental colleagues and to our Manx Care, Manx Terms and Conditions, the MPTC and NJC group, which is predominantly nurses, allied health professionals. We have the offer made to medical and dental has been rejected. The offer to the MPTC NJC group is currently subject to balloting. What has come through from all of those negotiations is the desire by all unions to work to a 3-year pay settlement. It is really high up on their agenda. And when Manx Care was created in 2021, they were just coming out of a 3-year pay deal. So a 3-year pay deal is the norm and the expectation for staff here. Obviously, we have certainty over what we could offer this year. We have a level of certainty built into the budget about what we can offer for next year, but obviously trying to achieve that over 3 years is more challenging, and therefore we have sought the advice of the Department of Health and Social Care in discussions with Treasury about what we could, whilst that might not be a fixed percentage, offer in terms of way of a narrative and assurances around a pay offer which would be linked to inflation in year 3. So we will have the outcome of the ballot for MPTC NJC expected by the end of February, beginning of March. At this moment in time, we are not able to put a revised offer on the table for medical and dental colleagues, but it's something we will continue to work upon. I think the important thing, what we are trying to achieve now, is to at least start to plan and have the negotiations for 24-25 sooner.
Yes.
It was a great source of stress and anxiety to everybody concerned that when we received the 2% in the budget for 23-24 and we used that to achieve settlement for the previous year, we did not have the funding to be able to put a pay award on the table until very, very late in the year. And I don't think we want to be in that position again. So whilst we're keen to conclude this year, we equally want to make sure we are starting those pay negotiations as soon as we can, as soon as the budget is agreed with us in late February.
Thank you. Any comments or questions? Tim?
Just to congratulate the team on having got the right pay negotiation in the right year. Because it does seem to me that the discussions we've had have constantly been about previous years and the current year, and I think to have actually put that to bed and to have brought things into more order is an achievement. I just wanted to recognise that.
Yeah, no, thank you. And I think it is a testament to the positive partnership workings we have with staff side. You know, it has been a very, very difficult period, but actually I think those pay negotiations have been conducted respectfully, collaboratively, and both understanding from both sides. We're all aiming to achieve the same ends for our staff, with clarity over the settlement, clarity over back pay and how that will be managed.
Yes. I think that relationship with staff side is one of the best I've seen, actually. And I think it is, as you described, Teresa, very respectful and, you know, with challenge, of course, but very respectful. And I think the hard work that's gone into that on both sides should be commended. Any further questions or comments? Thank you. So, Miriam, coming to you, please, if we may, for the workforce and culture update.
Yes, thank you, Chair. So I have been in post now for nearly 3 months, so I have spent that time trying to understand the context of Manx care and the wider issues in relation to health and social care on the island. And I think it's important to note that delivery of health and social care on the island is not new. However, Manx care as an organisational identity is. And I think that, for me, has been the real challenge. You know, it seems obvious, but quite often it is forgotten that everything starts with the people. Without the people, you haven't got a service, you haven't got anyone delivering anything, you haven't got anyone receiving anything. And I know that sounds like an obvious statement, but it does tend to get forgotten. And my short experience is that the goodwill of the staff in Manx care is just absolutely superb, and they are really experienced and really care about delivering things on this island. And that is part of, I think, it being an island culture. And I think the evolution of the organisation and the identity of the organisation, both as a brand but also as a basis for a psychological contract, is really starting to form now. And you know, Teresa's comments earlier about being pleased that she's seen improvement in transparency and trust from the team she's visited over the last week is kind of testament to that. I think, though, that there is more work to do in terms of that organisational identity. And in my report in section 2, you can see that the initial board structure that was put together with specific reference to workforce and culture development for Manx care is very similar to what we have now. It hasn't changed that much. But the reality is, in terms of the content of what we are working to around workforce development, just because of the governance structures around the Transformation Directorate, means that we don't have much control over that in relation to the detail. We have control strategically, but not in relation to the detail on a day-to-day basis. And the Workforce and Culture project team started as a project team for transformation, and is still functioning as one. But in reality, we're expecting it to deliver all of our kind of organisational development interventions in terms of culture. And without control over what they do on a day-to-day basis, that's quite difficult, I think, for the organisation to do that. And really, you know, this is not to do with it being a shared service particularly. It's to do with how much input we have over what they do on a day-to-day basis. There is no internal resource at all for organisational development. We have a set of really, really experienced and passionate managers. However, you know, without a kind of organisational development framework, how are we ensuring ourselves that they are being continually developed in terms of the new ways of working, but also their own personal and professional development in those sorts of ways? And the first thing around that is that there's a lack of connectivity. We've talked a lot today about data, where we get information from, etc. And there is a real lack of connectivity in the people space between process, data, policy, development, and all of that for me should be linked to the employee journey in terms of when we're onboarding, what we do to develop and support people during their journey with us, and at the point that they leave. And a lot of my report lists those areas where my work is being focused, but the bottom line is it is that connectivity between those things that we really need to work on. And some of that we've got control over and some of that we haven't. So in reality, another big gap for us is that people and professional development. The tools are available through the central government system, but they're very generic. They're not healthcare specific, and there's very little connectivity around management and leadership development. We have the experience, we have the knowledge, we just need to connect it all up together and to take some of that control internally, in my view. As Teresa's already referenced, the Office of Human Resources, who provides our shared service, has been reviewed externally, commissioned by the government, and it's been judged to be significantly under-resourced from that kind of external place. And part of the recommendations of the review included the establishment of a dedicated Director of Human Resources. However, that post, as Teresa's identified, is not at an executive level and will still sit externally to the organisation. That post has been appointed to internally, and the successful candidate takes up post on the 26th of February. But that review was very much of the Cabinet Office, wider government shared service. What it didn't do was address the internal gaps corporately for Manx Care around development and people management. So in terms of the activities that I've been undertaking in my first 3 months and the plans for the next 3 months, there's some work to do around the corporate people risks. We currently have a corporate risk of competition for staff being a key issue. We've been reviewing the content of that risk, but the reality is we need to look at the people risks right the way through. Because the way our risk management works here, the Office of Human Resources holds those operational level people risks, and we don't have much connectivity with that. So part of that review is not just the kind of high-level corporate risks, but that detailed understanding of where those people risks sit and a proper risk score going all the way up. We have a confused picture around HR policy and processes. That, again, is not our fault. There's an awful lot of work being done through the partnership agreements, which are excellent. But what we are wanting to do is create a specific suite of people policies that are Manx Care specific. Again, it's part of that organisational identity piece, but also gives our managers clarity on how to manage their staff on a day-to-day basis. Lots of the policies that we still have are legacy from previous organisations and iterations, and some of that is driven by other departments. And what that means in practice is employee relations issues are much more difficult and complex to manage here than they are in other environments. So I think that has created a pressure on the organisation which is unnecessary. And it is possible for us to relieve our pressure in that sense. So as part of that, I'm redrafting the governance route for policy agreement in partnership with our staff side colleagues, so that we've got transparency and clarity for Manx Care in the setting of our own people policies. Similarly, the various kind of culture and organisational development plans have evolved, as they quite rightly should have done at that time, from where issues have been raised from the ground up. So we've got the barometer of care that's come through from our medical colleagues, and we have the people and engagement and culture strategy, which was developed by the CEO last year, which is an excellent piece of work. Again, what we need to do this year is we are now at the stage where those plans need to be kind of overlaid with one another, so we've got clarity of purpose and we have one plan in terms of our organisational development. We will be going out for more data. We have the BMA survey going out, and we have just closed the staff survey, and we are hopeful that the workforce and culture team, and I say hopeful deliberately because, again, we don't have control over how that's worked, that the workforce and culture team will have the capacity to complete the analytics for us in that period. In terms of equality and inclusion, we have that sense of identity and the sense of belonging to an organisation, utterly key. But in order to do that, we have to make sure that we have equity and that we have a culture of inclusion within the organisation. We do have some champions that had come forward to be ED&I champions, but because of lack of capacity, not a lot had been done with them. So we've held a workshop this week, which has given us some really clear data about where the drivers are from those individuals, and to pull together a strategy in terms of direction of travel around that broader belonging piece and the legislative requirements and the cultural issues underneath it. And as part of that, we're scoping out some staff networks. We have scoped the role of the network leads, and we are focusing this year on our BAME colleagues, LGBTQ+, and disability in relation to having those staff networks. These are a crucial part to give information up to the board around where issues are for those protected groups. The rest of it is around those sort of activities that come from that original transformation plan. And one of the pieces of work that we've undertaken is to align that plan with the people and culture and engagement strategy, so that the management of that work can be all in one place and can be really clear in terms of the evolution of the organisation and the direction of travel in terms of where it is now in its organisational development journey. Coming back to the data point, oversight of data is a real challenge, and we've talked about that a lot today. What I've discovered is the people analytics team in the Cabinet Office do use up-to-date tools like Power BI, but the data feed that they are getting is not necessarily always accurate. And, you know, David's point about spreadsheets, that's exactly where things like employee relations casework is being stored in the Cabinet Office. So the feed to Power BI, you know, rubbish in, rubbish out in terms of that information that we're gathering. So there's a lot of detailed work to do around that, and that is not going to be a quick fix, as I said earlier. Recruitment and retention, that is a key risk for us. There has been a really good piece of work around recruitment and retention. But as I've said, the corporate risk is around competition for staff. And that focus on retention needs to be linked back to the psychological contract and that feeling of belonging. And that is that systemic and connected approach, really. And it needs to be aligned to that people risk. Workforce planning has been raised this morning in terms of the future planning. What we're doing at the moment, because there is little data that we can put our hands on, is we're doing a manual process within the workforce and culture team to work individually with different departments to look at capacity and demand, the organograms, the career pathways, skill profiles, etc. Again, that's going to be extremely labour intensive if we continue to do it in that way. So we do need to give some thinking to how we deliver some of that future planning and to get a baseline for now, which is really what that work is going to be delivering. I think I'll leave it there, Chair. I think that's, that covers most of the points within there.
Thank you. Any comments or questions for Miriam? Teresa.
Thank you. So I think that there is an awful lot of work going on. But it feels, as you've highlighted, disjointed, uncoordinated, in separate silos, not pulling together. So we don't feel the benefit of that work. We're not feeling the impact of it. We're not quantifying it. We're not setting clear future plans. And it comes back to perhaps some of the themes throughout the whole morning of, I think it's really important as a board we define what our shared service arrangement needs to look like. So what we need from the shared service and what functions as a shared service where we've got the efficiency and the cost effectiveness of having the benefit of a shared service. And then what as an organisation do we need to overlay on top of that? And I think you're in a unique position, Miriam, to help us define some of that, but I think we need to work quite quickly now because we need to set some very clear plans in our budget setting for 24-25 as to how we respond to that. What questions do the board, what decisions do the board need to make in that space? And, you know, I have to sort of come back to sort of 12 months ago, the board made the decision to bring finance, estates and digital into the executive space more formally of the organisation, and consequently Jackie was appointed. And I think we have seen significant benefits from taking that step of bringing that function into the Manx Care Board at an executive level. And I would like to think in 12 months' time we can describe the same level of progress around the people and workforce agenda as what we have seen. We've sort of tested it and we know it works. We can make that relationship between shared service and executive space work. It will be about the relationships, but it's having that ability to really move things forward.
Yes.
I'm incredibly frustrated that we haven't made more progress on this agenda than what we should have done in the last 3 years, and I think it's lagging way behind where we are in every other aspect of our business. So it might not be a realistic ask, but I would almost like to think that for the next board, we could have done some of that detailed work on what bits of the shared service are fine, how that needs to be rewritten, and then ultimately what is the gap for the board to consider where we take Manx Care in 24-25 in that workforce people space.
Yes, Miriam, do come back, but I'll just bring Nigel in first, if that's okay. Yes.
Thanks, yeah. Miriam, terrific paper. Thank you very much. I think it's really insightful, and I think it's right on the money, and I think it's absolutely where we want to be. What do we do with it? Teresa's already outlined that, and I think when you're managing change, and you've got lots of good people working together in different ways, but you're seeking to bring about change, the danger is some people feel threatened by that. I think we've got to get rid of any concerns about threat. We've got to go in the same direction, and we're going to have to work very hard
to convince colleagues to work with us to bring about that change. But you only get change if you appoint somebody to the task, you give them time, space and responsibility and the budget to do it. So it's imperative that we take control of this somehow and define our relationship with shared service. And we've been bedevilled, and we'll come on to finance shortly, by responsibility without control. And that is the current theme that is coming through here. And unless we start somewhere to solve that, we're going to be having the same discussion in a year or two's time. We've got to look 10 years ahead and define what kind of organisation we want to be, what kind of service we want to provide for this island, and define it and then fund the gap of where we are now to where we want to get to. And that's the only way we're going to do it, by employing the right people at the right time, the right place, and giving them responsibility and the power to make changes.
Yeah.
So thank you. I think it's great that you've highlighted it. It's concerning to read, but I think to get it on the table and to get it out in the open is just such a positive step forward. Thank you.
I mean, just to, I'll come back to Nigel first. I think, you know, at this point in time, I'm here for 6 months. I'm going to be here until the end of April. You need to get proper bang for your buck out of me, in reality.
I think we are.
Thank you. But in terms of that, you know, it will be a waste of your money and your time if I come along and I don't share with you the realities of what I'm discovering. So thank you, Nigel. That was really positive feedback. I think in terms of Teresa's ask for the next board, I think that is perfectly possible, because a lot of the work that I've been doing over the last 3 months, for me to be able to put something together for that, because a lot of the work that I've been doing has been that discovery phase. I mean, that has been challenging around, you know, the politics and the context, as everybody would expect, but equally in terms of that threat piece, you know, that whole kind of concern that people hold of there's a new person in this space and we don't really understand what that person's here for, and therefore they are threatening what I'm doing. If they're looking at what I'm doing, then they must be going to criticise that. And the reality is the people in the shared services, the vast majority of them are working incredibly hard and are very knowledgeable. That is not the issue. And the issue is around how those things connect together. So a small example would be around the recruitment and retention work. It's our key board risk. We all know that getting and keeping staff is a challenge in all healthcare, but in this island setting, even more challenging. The OHR team recognised that and did a whole load of work on a policy. The workforce and culture team recognised that, did a whole lot of work on strategy. But those things weren't connected together. They weren't talking to each other. And, you know, that's because of the way they're structured. And because we don't have that control in terms of managing them, we're unable to instruct on that. We can just request.
Yeah.
So that piece around defining what we want from our shared services in relation to those economies of scale, transactional elements, you know, the drafting of a new service level agreement is a piece of work that I'm doing, but that's not the end of the story. It's also how those teams themselves connect together, and a reflection, I think, for the board on where those areas that we do not control, where they're not connected together, are we just going to separate that off and keep an element and manage that ourselves or not? You know, so that reflection is part of the work that I've been doing for the last 3 months, so I can crystallise that into a paper quite easily, Teresa.
Thank you.
May I?
Yes,
Yeah,
please.
I absolutely agree with you, Miriam. And I think as a non-exec sitting on this board, one of the observations I have is that because there is tension in finances, there's tension in staffing, there's tension in the service, that's cold comfort. We're not alone, but that is cold comfort. We spend a lot of time managing stuff and sometimes you have to step back and work on the business, not just in the business. And I think that's going to be a challenge for us for this year in particular, in justifying our position in terms of our relationship with government for funding. Also, we have a change in direction of the board. We have a new chair who's here with us today, and I think that will provide us with an opportunity to review and reflect And I hope that maybe one of the things we'll do very shortly is spend some time stepping back and working on the business, not just in the business.
Yeah, definitely.
Thank you.
Thank you, Nigel, and thank you, Miriam, for the paper. I think, as Nigel has said, it's really good to have it all written down in one place. And, you know, it is a cause of concern for me as the chair of the People Committee that I can't provide assurance on things to the board that we need to be able to provide assurance to the board on. I was very pleased to see the establishment of the networks, or the emerging establishment of those networks. Tim and I remain the board champions for ED&I, so whenever you would like us to get involved in those, please let us know. And just a question about the staff survey. So that's obviously concluded and is being evaluated. Do we have any idea about how many staff responded?
Well, on the question of data, I asked that question when I first started in terms of what's the progress on that. And oddly, the first time I asked the question, I was told 23% had responded, and the second time I was told 20% had responded. So that again is that challenge.
But it's being managed by an external provider.
It's being managed by the Workforce and Culture team.
Oh, okay. I thought it was being managed by the.
It's not picked up. No, they couldn't do the analysis.
Okay. Oh no, I recall.
So the data is a challenge in terms of that. Now, when I've looked into that, it was just the difference between headcount and full-time equivalent. So they'd set it at a level and then it had gone down. Overall, the last I got when it closed was that it was still at 20%.
Okay.
Which, in terms of response rate, is not great. But it's not the only way that we can find things out.
No, indeed.
So the analytics of that, as I say, I should be in a position, you know, capacity in terms of that team, allowing to bring back the results and the analysis of that staff survey in March. But I think we've got a lot of work to do.
So it should go to the People Committee first?
Well, of course, yes.
So it might not be March, might be April.
Of course, the People Committee isn't until March, so yes,
but
it might be
if we
April.
needed to have a... Let's talk about that offline. If we needed to expedite that, I'm sure we could do that. Any other questions or comments for Miriam?
Just a minor technical
yes,
point.
Jackie.
When we're calculating the response rate to the staff survey, I think we need to be careful of the denominator, or we'll end up in the same position we did on the vacancy rate.
Yes.
Is that we're calculating the response rate on the figures held centrally for what our staffing numbers are is higher than what they actually are.
Yes.
So we could find that it's similar to the vacancy rate.
Absolutely.
It's actually a higher response rate.
Yeah, just to further illustrate the point of data. Thank you. Jackie, coming to you now for your finance report and the management accounts, please.
Great, thank you. So just briefly I'm going to do the management accounts first and talk about our current year financial position, and then I'll move on to an update on our preparations for next year, for 24-25. So you'll see that we've had a large movement in the forecast this month of 3.1 million, an adverse movement. That's really just moving some of our risks that we were holding have now crystallised around run rate, about SIP achievement and all of those things. So we're now reflecting those in the forecast. We are all still holding approximately £2 million worth of risks. So they are primarily things that we think could happen to us between now and the year end, but haven't shown in our actual run rate so far. So one element of that is if we continue to experience winter pressures for a prolonged period of time and we need to deploy additional resource in order to respond to those, and I think we've talked a little bit about ED and things like that, and we've had that response, then we have a risk that we may need to spend more on that towards the end of the year. There are also some other risks sitting in our run rate that are being mitigated at the moment, but if they don't get fully mitigated between now and the end of the year, there's a further risk of about 900k in that. There are a couple of other risks, so they're the main risks, and I would say that the likelihood is that they are probably going to translate between now and the year end. And we're now into Q4, so our ability to respond to any major deviations or incidents in this last quarter are very, very limited. So any unexpected expenditure that now arises in the last quarter of the year, we don't have much capacity to deal with that, and that's what these risks are designed to do. So if all of those risks transpire, we will land within the 30 million amount that is the amount that's being requested of Tynwald in our supplementary vote. So that's going to Tynwald this month. It's been, we'll all have seen it on the news. So we are doing everything we can to land on or below that 30 million, but I think, as I've said at previous board meetings, that remains a challenging position. We are doing everything we can in terms of visibility and control over those things that we can do between now and the year end to make sure that we do that. I think we've got, in terms of the SIP, we have been performing really, really well on the SIP, and actually in the last month we have increased the target to the end of the year from 6.4 million to 7.5 million. That's because when we last reviewed the numbers, we were at 93% performance, and we knew there was more to come. So we are at 5.9 million of SIP savings this year, 4.9 of which are cash out savings. Now, all of those savings, even the revised SIP target savings, are being reflected in our forecast. So they don't help the forecast position any, because we've already taken those savings into account. But I think it's important that we maintain that pace and that impetus to the end of the year, so that we can be very clear about we are doing everything we can to mitigate our spend wherever we can. There's also an enormous amount of work being done in terms of developing work streams that will deliver into next year. So we always have this balance in our SIP programme every year of the stuff that will give us savings in this year and the stuff that we have to start in order to deliver savings in future. So we're really, really pleased with the SIP. The other thing I want to draw your attention to, because I know there's always a lot of interest in it, is our spend on bank and agency. So one of the big success stories of our SIP has been our efforts in recruitment, and so effectively replacing vast swathes of our agency cost with substantive staff this year. So clearly that has a massive financial impact, but I think more importantly it has a greater impact on our stability of our services and the quality of the services we provide. But if we just look at the charts in the management accounts, our agency spend this year to date is £2 million lower than it was 2 years ago. Now, given that agency rates have increased dramatically in the marketplace because of demand, that tells us really clearly that we are all over trying to absolutely minimise agency spend wherever we possibly can. And we do regular reviews now of those agency positions and where they are primarily in those services which are fragile and without that support would actually collapse and fall over. So we're targeting it at that. The other one I want to draw your attention to is bank spend. So bank is obviously where our own workforce take on additional shifts and additional work. And anytime we agree a pay rise, so anytime our underlying pay rates go up, the bank rates go up the exact same amount. So if you look, our bank spend is at about the same level that it was 2 years ago. And what that tells us is that we've had sort of close to 10 to 12% pay rises since that time, and our our overall spend level has stayed the same. So again, that tells us we're also using less and less of that temporary bank staff to actually provide our services on a day-to-day basis. So I think it's important that we note that progress, and that's largely driven by very successful recruitment efforts. There's more to go at, but I think we'll in a system like ours, we always have a level of temporary workforce that we can expect to have. So that's primarily the management accounts. In terms of our position to the end of this year, I thought it would be useful to just go through how we've gotten to the position of needing 30 million extra in the year. And we had this conversation with some Tynwald members yesterday, but I think it's useful for the entire board to be aware of. So we ended last year with an overspend of 9 million. And that was not because there were one-off things happening. That was just our underlying run rate. So that had to sustain itself and continue through into this year. So we started the year 9 million behind. On top of that, last year, roughly 9 million of pay costs associated with the pay awards was funded directly from Treasury for that year. but we had to take those costs into our baseline for this year. So we started the year £18 million down. We received £20 million worth of funding. So we started the year with £2 million to play with to address any and all of the financial pressures that we faced in this year. The vast majority of that extra, so we're going to spend an extra 32 million this year compared to last year. The vast majority of that is on pay. Big proportion of that is around pay awards, so just paying the existing staff higher rates. But another big part of that is where we've made investments in services to bring about safe staffing levels. So we've made investments in our nursing workforce, in our ED workforce, in our social care and our midwifery workforce. We're also now having services or business cases that were previously funded by transformation or elsewhere in the system. We're now taking the costs of those. So things like the COVID vaccination team, for example, costs us close to £1 million a year. And that was previously funded through the COVID fund. Now that has to come into our baseline. Things like our frailty service, our CFSME long COVID service, our diabetes service, and various other things like that. So we've taken on the cost of existing business cases. The other really big area is where we're seeing inflation on our contracts and supplies spend. So last year, we held inflation on many of our contracts to 3%. We negotiated 3% increases in the face of 10% inflation. What now is happening is that 10% is now being honoured in this year, so we're seeing increases of 7% and more on some of our contractual spend. It's also worth noting that because so much of our contractual spend is delivered using people on island, particularly in our social care side of things, any increase in our underlying pay costs are reflected in the costs of the people providing those services to us. So they also impact on our contract costs. So I think containing those contract costs to 10% over that 2-year period, again, has represented a significant efficiency, but that pressure just keeps building. And then we've had some additional services around safeguarding and so on. So you can see that the vast majority of the pressure that's been exerted upon us this year is, I won't say it's largely outside of our control, but there's minimum things we can do to address those. So, pay awards are driven by the environment that we're in. And as Teresa said earlier, some of that is driven by the fact that a third of our workforce negotiates separately with government. And when their pay award comes out ahead of negotiations that we've concluded, that creates actually the base expectation. So, if 1/3 of our workforce are given a 6% pay award, you can't really go to the other 2/3 and offer them 4%. So that creates all of that pressure. So I just thought it's useful to understand that. Also, just looking in terms of the wider context around Manx Care since its inception, we've seen since April 21 inflation on the island of about 20%. Our spend during that time has increased by 19%. So we've held our spend at lower than inflationary increases, which is a massive achievement, not least because we experience growing demand in our services. But also we've managed to do that without actually significantly cutting back or constraining our frontline services. And I think it needs to be recognised just how significant that is. Normally, if you're holding spend below inflation, you're cutting stuff. You're cutting stuff back. And the way we've been able to do that is through being efficient, about being innovative, about doing things differently, about doing things better. The SIP programme captures a lot of that, but there's a lot of that that's happening that's not formally captured and measured by the SIP programme, but it's evident in the figures. However, that rising tide of demand that's coming at us is not going away. And I think what we're starting to see is that is inexorably, it's not even coming at us, it's here. And our ability to meet that demand is seriously constrained by our financial envelope. And I think what we can, I won't say look forward to, but what we can expect is that pressure to just grow and grow and grow. And it will start impacting on what we can actually deliver within the financial envelope. So I'll pause there before talking about next year to see if there's any questions about this year.
Thank you, Jackie. Any questions or comments?
I think that's a really good result in the circumstances, you know, and I think it demonstrates that we're doing the right things in attempting to be proactive, particularly around workforce management. I remember when I made changes to the nursing workforce models, how the levels of anxiety when I said we're going after agency with a view to getting rid of as much of it as we could, and the concern people had, and the scepticism that by replacing that with substantive employees means that ultimately we spend less money and we get a higher quality service for patients. And it's really encouraging to know that that work we started in this board 2 years ago has paid off, and I think has set the foundation for other disciplines to do the same, precisely the same thing, and not to be afraid. And it's hugely encouraging, and you know, hats off to you, Jackie, for your assistance in guiding us to an outcome which is really very positive, even though we are technically in deficit. I think it's a very positive financial result, if you don't mind me saying.
Thanks, Paul. I appreciate that, because it's easy to look at the big number and go, 30 million, that is a really large number. It's 10% of our budget, but I think it highlights what we've been talking about here as a board, that we have things to do in terms of using taxpayers' money efficiently and wisely and carefully. But the other side of that is making sure that the underlying funding is actually appropriate for what we're being asked to deliver. You can only achieve so much through efficiency.
Marina.
Thank you, Jackie. That was really helpful. For me, the best part of this is the fact that it's not had a massive impact on clinical service delivery. And yes, we've got to be fit with the money, but we've also got a job to do, which is to deliver quality clinical services. And my wish for next year is that as part of that, I'm bringing in what Miriam said earlier in terms of connectivity with people who are our most important resource. I'm talking about doctors here now, is allowing our SAS doctors to have career pathways and allowing them to move on to be associate specialists, because that will motivate them, and see how through job planning to budget, that you've taught me, Jackie, we can actually make this happen and be effective. Thank you very much.
Thanks, Marina. I think what I see beginning to happen is the green shoots of our data is maturing, even though it's not where we're at yet. Our information, our knowledge about our services is maturing, even though it's not where we're at yet. Our financial grip and control has definitely matured, but there's still a way to go. And I think we're reaching a position now where we can actually start to properly articulate what we've got on our hands and what we might do to respond to that and what that might cost us. And we're not there yet, but I think we're much further along that route than we were 3 years ago. And I think that will help us in those future conversations about the true meaning of sustainability, is that you spend and your funding align with one another.
Yeah. Thanks, Jackie. Nigel and then Paul.
Yeah, I think I also want to say thank you for talking us through what, at face value, could be a very bad result. And I think the difficulty here is that the numbers do tell a story, and you have brought them to life, and I think that's a great skill. It's one I admire greatly. You know, often you purely look at the numbers, but actually it's the story around the numbers. It's the context that's really, really important. And through FP&C, which, as colleagues know, I chair, there is a very robust process of looking at these numbers on a monthly basis. We debate hard and fast, and we've created an environment of support and challenge, getting the right people around the table, senior leadership team, managers around the table, who feel that they can debate and they can tell the story openly and honestly. And I think that's a great move as well. So although one narrative would be £30 million is a desperate state to be in, we need another 30 million. What's happening? The runaway train. Actually, it's not like that at all. No. Actually, we've done incredibly well and you should just pause for a minute to reflect on that, when you consider the external non-controllable factors.
Yes.
Non-controllable factors that have
Yes.
been levied on us. And the other point I'd like to raise is that I think Jackie's appointment to this board as an employee of Manx Care, not detracting at all from the shared service we get from Treasury, because what I observed, and over a long career, believe me, I've seen the good, the bad and the ugly, we get an extremely excellent service from shared service. And colleagues there, although they are paid by Treasury, actually their hearts and minds are with Manx Care.
Absolutely.
And that's going back to what Miriam was alluding to, that psychological contract, that feeling of belonging. So, you know, I have no concerns about the efficacy of the monthly management accounts that we consider. And I have no concerns about the way in which we're delivering it. But clearly, funding is a difficult conversation.
It is.
Yeah.
And, you know, I'll come on to it in a minute, but I recognise that, you know, simply going cap in hand asking for more money all the time is not the way to do it. We need to, as Paul said earlier on, we need to justify every penny. We need to explain why it's necessary, and we need to explain the impacts and the consequences of
Yeah.
whatever decision we choose to take.
Yeah, that was
And
going to lead me on to my point, really, building on what Nigel and Marina said. So, you know, I'm conscious that my contributions have largely been about bringing some sense of perspective that we achieve a balance between the safety and quality care needs as well as the needs of achieving a financial outturn. And I think that is absolutely right. And I think while we have to be preoccupied with ensuring care is safe, I also think going into next year, it would be useful to have a similar preoccupation with value for money.
Exactly.
And knowing that we're extracting from every pound that we spend the very best that we can for that amount of money, which I think takes us into a very different space.
Yeah.
And might actually help us actually envisage the tension between quality and finance in a very different paradigm that might actually alleviate some of that tension that we experience as a board.
Thank you, Paul. I think it's really important to note the conversation that we had yesterday with Tynwald members and the maturity of that conversation. And I think, you know, telling the story about what is possible and what is not possible within the current funding envelope, but also for the future, was really a step forward. But I don't want to steal your thunder by what about you're about to say. But Wendy, you have a question.
To preface what I'm going to ask with, I thought the performance yesterday was excellent. I thought the team was not just corporate but confident, and I think it's highly unlikely that you won't get the result from Tynwald that we hope. But is the Finance and Performance Committee looking at contingency plans for if the 30 million is not supported by the vote in Parliament?
I can answer that.
Thank you.
I have to choose my words carefully. Precedent tells us that supplementary votes are almost never rejected. In terms of our ability to, between February and when the decision is made and the end of March, to make any significant difference to the final position is pretty much nil. Okay. So I think those in the room discussing the supplementary vote are mindful of that.
And I think we saw a reflection of the quality of the information that was shared with members yesterday, and perhaps some people leaving that room with a different view of the focus that this organisation has had on its numbers, on the relentless, you know, budgeting that has gone on in each care group, and on the impact of external factors to where we find ourselves. Yeah. And you know, let's hope that we get the outcome that we need.
Yeah.
I think I'd
Sorry,
like
Nigel.
to also talk to Wendy's point, if I may, please. I think you raise a very important, very difficult point, Wendy. And so, yes, there are plans, but not in this year. And I think those plans define a different service, to be honest with you. And Jackie talked about, you know, inflation being 21% and us actually spending 1% less than inflation. What she didn't talk about was the differential between our funding and what Jonathan Michael predicted our funding would be at this stage. And that is a massive number, and I'd like you to cover it technically, Jackie, if you wouldn't mind. But I think I would go back to say that we all signed up to the Jonathan Michael report. Not only Tynwald, but the board of Manx Care too. And I think the reverse Jonathan Michael report would be very unpalatable if we are not in a position to reach some kind of accord over funding in the future. It raises issues over safety, I think it raises issues over professionalism, and I think it raises issues over the integrity of this board, and that would be a difficult place to be.
That was not a strategically timed sneeze.
Sorry.
So just Nigel's laid the groundwork perfectly for me there. So for next year, so also at February's Tynwald sitting, they will consider the budget for all of government. And we as a board have been aware for a little while now of what the proposed settlement for next year is, which is 347 million. In terms of your point there, Nigel, the Sir Jonathan Michael's funding formula and the projections we do using that formula would suggest that an appropriate budget for 24-25 for Manx Care would be closer to 390 million. So that's an enormous gap between what our modelling tells us, and even that modelling based on demand growth, I think we will need to address in this coming year, because what we're consistently seeing is our growth percentage is 3%, and we're seeing growth in demand across many of our services that's multiples of that. So I think in the coming year we are going to need to look at that to make sure that we understand that correctly. But if I talk through next year in the same way I've explained how we've arrived at the end of this year. So we'll begin on the 1st of April. Well, we'll end this year spending, I suspect, around about 338 million. We've got funding of 347, so we have 9 million to play with for the coming year. Anticipated costs of pay awards alone is likely to be between 8 and 9. Inflation is likely to be somewhere between 7 and 8
million.
Yeah. And that's before we get into existing things that are in the system. So again, prior year business cases that now land on us, any of the investments that we would like to make in our services, all of the improvements that we want to make, addressing our demand, addressing our quality and safety standards. So I think we need to think very carefully as we come into this next year, because as Paula said, I agree, I think we've managed that balance between quality and finance relatively well so far. But I think with the envelope that we've got for next year, that is going to come under increasing pressure, and our ability to manage to actually allow those two things to manage as they have done. Value for money on its own is not going to deliver the level of service that I think we would all want to deliver, and certainly what the public would expect us to deliver. So there are some difficult conversations that we're going to need to be having over the next few months about what our health and social care service looks like going forward. Part of that conversation could be around constraining services, but we always have to remember that we have an obligation that whatever we run, it must be run safely. And if that means that our base safe level running is over and above our financial envelope, then we have something to do about that. But the other things we need to start looking at are, as Oliver mentioned before, eligibility criteria for access to some of our services, charging for access to some of our services. So, you know, our prescription charges on this island are way off what it costs us to deliver those, and way off what you'd pay in similar jurisdictions. Our dental charges, for example, haven't increased since 2015. So there are plenty of things in terms of generating additional income to offset our costs. There are also opportunities about the way we commission some of our services, the way we provide some of our services. So in some instances, it may be more appropriate for us to internalise services, and in other instances, it may be more appropriate for us to externalise. Now, I need to be really clear when I talk about externalising services, I'm not talking about privatisation, because I think a lot of people misunderstand that sometimes. What we're saying here is, and we do this all the time, we provide services all the time through third parties. We commission them to provide the services on our behalf. That's part of our contract. So there may be areas where the market can provide that much more effectively, much more cost effectively than we can. And we need to examine all of those options in terms of making sure, as Paul has said, we extract every ounce of value from every pound that we spend next year. So these are all the big questions. So in terms of process, between now and the beginning of the financial year, we are attempting as an organisation for the very first time to do some bottom-up budgeting. So all of the individual care groups have been given their target budget for next year. And what that does actually, for many of them for the first time, is it actually gives them what they're currently spending. Most of our care groups have started the year in deficit positions because we've never been able to give them that money before. So the award for next year is a massive, massive increase, and we have to be mindful and thankful for that in the current circumstances the government finds itself in. I think Treasury and government are trying very, very hard within their financial constraints to meet our demands and our requirements. So again, for the very first time, we've started a budget which actually covers what we're spending, even though it doesn't leave much left over. So we've been able to stabilise budgets across the care groups to what current spend levels are. Now, what that doesn't cover is inflation, pay, and any of the extras. So that's their efficiency target, is agreeing those. So what they're being asked to do is to very clearly describe to us, what does the money buy us in terms of service delivery? What can we afford with this money? And more importantly than that, that they're being asked to describe is, what does it not buy us? So we can see where those gaps are, and we can understand as a board and as a collective where the risks lie in terms of constraining ourselves to that 347 million. So there's some big strategic decisions for us to be considering and taking over the next weeks and months about those risks and what we do to address those.
And Jackie, I agree. And just to build on that, I think it will be enormously helpful to know what the money will buy. But I actually think, in addition to that, it would also be helpful to know what our reference cost is for each clinical procedure or each piece of activity or each pathway episode of care, because I think it'd be good to know how far away are we, because that might give us insight into where there might be opportunities.
Yeah, completely agree, and I think that's part of that work stream around activity-based costing. We're not at that level of maturity yet, but I think what we do have is a lot of the work that's been done with Oliver's team around that demand and capacity modelling actually gives us some of the data about our activity, which up until now we didn't have a lot of visibility on. You're absolutely right. The next step is then to start assigning costs to those. But I think, in all honesty, that's probably a year or two away before we can do that in any meaningful way. So in the meantime, we've got to use the various proxies and our intuition and our knowledge and experience to try and come at some of those.
Yeah. Oliver.
And just to say that sort of that good understanding of what each thing costs is also vital for what our left shift project and that cost saving, which is, once you know how much it costs, then you can justify or not moving it into a cheaper form. For example, secondary care to primary care. And we've certainly struggled sometimes, haven't we? Because we struggle to know how much something costs, how much resource is moved.
I think you're absolutely right, Oliver, and we do need to be mindful that in sometimes this exercise somebody will say, well, I'll just stop doing that because it's cheaper for me, and then we'll do it over here, and doing it over here actually costs more. So we keep it where it is, even though it's a pressure where it exists. But I think the other thing about the shift left, which I don't think was probably fully appreciated at the beginning of this, when we embarked on this project, is that I think there was an expectation that we could pick money out of the acute sector and put it in primary care to stabilise and to fund and to support all of this activity that we want to do. And I think what we found is that even if you take this activity out of the acute sector. Because we've got this huge wave of demand sitting outside, as we take money, as we take water out of the bottom of the pail, it just keeps pouring in through the top. So what we end up with is it is more expensive overall to run the service, but we are doing more with that money, and we are getting better value for that money. Whereas I think previously there was an expectation that we could just sort of move the pieces around the board a little and the overall envelope would stay the same.
Yeah.
And that's just not where we're at in some of this stuff.
No. Any other comments or questions for Jackie? No. Thank you very much, Jackie, and thank you for all that work that goes on behind the scenes. Nobody raised any other business with me, so that concludes the formal part of our meeting in public. Mr. Mann, thank you very much for your 5 points. We will consider those and come back to you in writing. Does anybody have any other further questions that they'd like to raise? Yes.
Can I just ask 2 little things? I mean, Jackie's just an awful act to follow, isn't she? What she said, which was magnificent. It's 2 things from the IPR. The first about stroke and cancer service. The first one is the stroke. If I were to have symptoms of a stroke and somebody call an ambulance to me, the target to get me into hospital is 60 minutes. You can flip a coin, I've got a 50-50 chance of meeting that target. Last year it was 36%. The year before it was 50%. It's just not moving. Why? Is it because the ambulance capacity is tangled up here with turnover being slow, or why is that?
Yeah, well, you've hit the nail on the head there. So the ambulance service, we operate 4 ambulances during the day, 3 at night. That level of staffing hasn't changed, hasn't increased since 1994 when the ambulance service was established, but the demand has got significantly higher since then. So, as you've seen in the other bits of the IPR, clearly we were always prioritising our Category 1 calls. We get around 3 to 4 Category 1 calls a day, and they're always the ones that are prioritised. You're right in noticing that we are seeing an increased number of handover delays down in ED. So 43 were reported in December, where the handover time between arriving and the crew being released more than 60 minutes, which is obviously a concern, but is linked to what we said earlier around overall demand in ED increasing and just the chronic lack of space that we've got there. So, Teresa mentioned earlier around the other things that we are doing as part of the urgent and emergency transformation project. So Hear and Treat, which is the presence of a paramedic or a nurse in the control room to signpost people ringing up to other services, which is having an impact, not as much as we hoped at this stage, but it is a long-term project that as we develop other services that the ambulance service can be, or people can be signposted to, for example, pharmacies, intermediate care, etc. And then the other piece of work which is in the process of coming on stream is the See, Treat and Leave, which is the us having advanced paramedics working alongside the double-crewed ambulances, the big ambulances, to support capacity with particularly those patients who have called for assistance for lower acuity calls. So, at the end of the day, the See, Treat and Leave paramedics are the first real substantive investment that we've made in the ambulance service for 30 years. And certainly that will help to reduce the workload on the double-crewed ambulances, which will mean that they can attend both stroke calls and other high-priority calls quicker.
Thank you,
I
Oliver.
would say that the stroke, I mean, Casey said this morning, weight equals worry. But in this situation, weight doesn't just equal worry, it's
Equals
disease progression.
permanent disability, yeah, absolutely.
And the cost to the NHS could be huge.
Yeah.
So it's really a priority.
I agree, yeah.
Understood.
Yeah. And we have that fixed asset, you know, and I don't think we wanted to go down that route of putting more ambulances on the road. That's really, really not cost effective. What we've got to do is reduce the number of people being conveyed to hospital by an ambulance who don't need to. So they can either be left in their own home with advice and guidance, diverted into a different pathway. So ultimately, the number of conveyances those ambulances are making is reduced, and that will free up the ambulances to be able to respond to the strokes and get that target and category 1 performance much, much better.
Yeah.
And that's where we talked earlier about really wanting to drive that level of improvement in the out of hospital space in those diversionary pathways and make sure those ambulances are used appropriately.
The other thing was the cancer services. The 14-day, the 2-week rule's gone now, and it's a 4-week rule. The 2-week rule that you did, your performance last year was 60%. Was seen within the 2 weeks. Now you've gone to 4 weeks. The 60% has only gone up to 66%, but you've got twice the time. Why is that?
Well, there's more stuff to be done within that 4 weeks. We haven't just doubled the targets. It's, you know, the 14-day or the 2-week rule was the time between being referred and being seen for the first time in clinic. The 28-day faster diagnostic standard requires the patient to have all of the diagnostics done and then have the results fed back to them within that 4
So you're
weeks.
not comparing apples?
No.
That's fine.
And that's why faster diagnostic standard is a much better outcome measure, because it says that by day 28 you are ready to receive treatment for your cancer diagnosis. Whereas then 14 days was just I'm being seen by a consultant for the first time. It's a much better outcome metric.
Does that answer your question?
Yes, it wasn't clear to me looking at the thing that
We are going
I was
to.
looking at apples and pears.
We are going to do some public comms this week, I believe, or next week, just around the change to the cancer waiting times, just so that people aren't under, you know.
You'll have to let us know whether it makes sense to you after you've seen the communications.
The breast issues that you've got.
I'll send it over to you, Lynn.
Okay.
Yeah.
Fine.
Thanks.
Mr. Mann.
It's an important clarification. Could I just add to the question that in light of what I've heard from the finance director, it seems to me that when you get this mandate, you're given a certain sum of money and you are now around the boardroom table working out how you can allocate that money. Well, but surely the position really is that Manx Care is a service provider and the Isle of Man government is the customer. And if you went out anywhere to any service provider and you asked for a range of services, the service provider would price up as near as they could each item. Now it strikes me that before the mandate is produced, Manx Care could do with producing the goods on the shelf. If you go down to the supermarket and you haven't got enough money, you get to the checkout, you have to leave some of the goods behind. And the government needs to know what goods it's leaving behind before it presents you with what its wish list is for the year.
Indeed.
Yep.
Indeed.
Now, we've talked to I've been to nearly every Manx Care meeting, and way back at the start was the suggestion of a 5 and 10 year financial plan.
Yeah.
But in fact, Manx Care hasn't actually produced one. A costed out 5 or 10 year plan. We've also discussed the dire need for a new IT system. But I've never in the public domain yet heard anybody put a figure to it. Now surely if right at the start we'd actually produced as a board, the board had produced a 5 or 10 year plan and had actually put a figure on the new IT system and said, well, this is the tool we need to improve our efficiency across this multi-million-pound organisation. You might have actually had it discussed on the floor of Tynwald Well, actually, Manx Care, in addition to providing their services this year, needs X number of £1 million for a new IT system. So,
do you mean the
reason for
Manx
my
Care
question-
record,
Yes,
Mr. Mann? Is that what you're referring to?
The
The Manx Care record.
No, the IT system that you need a new IT system because many of your systems are falling behind, they're outdated, and they're going to need replacing. And it's a major item of capital
understood.
expenditure.
Thank you. I'll ask Jackie to respond if I may.
It comes down to, again, the division between who owns what.
Yes.
You don't own the building.
No.
But presumably you own the desks and the bits and pieces around you. So if the desk broke, you've got to buy that, and you've got to find that within your budget.
I wish it was so straightforward,
Well,
Mr. Mann, really.
I've suggested to Mr. Wallace before that you need to now start putting Manx Care tags on everything. What you own, what you don't own, and therefore what government is separately responsible for paying for beyond your budget. It may well be that the IT system is an item that DHSC should be providing and not something that has to come out of your budget.
Thank you very much. Jackie, would you like to respond?
Yeah, so you raised a couple of very excellent points there, Mr. Mann. So first of all, absolutely, I would love nothing better than to be able to produce a 5 to 10 year financial plan for Manx Care. I think there's a couple of reasons why we're limited in our ability to do that with any great deal of accuracy. So, in my moments with my spreadsheets, do run out forecasts based on various assumptions. But I think there's a couple of things here for us. One is we're still discovering actually what we have and what we don't have. We're still discovering where responsibility for funding for many of our shared services lies, and we are finding deficiencies in many of those. We are still discovering what belongs in our estate, what we have and what we don't have. We're also still discovering how our system is evolving. So we haven't yet, as we talked about before, got the kind of technical capability to do that pricing exercise that you talked about. That's activity-based costing. So we're limited in our tools, but we are developing those tools. So that's absolutely an ambition that we will be able to do that. Projecting a 5 to 10 year financial plan is difficult, even with all of those things in place. Even with a stable system, that's a challenge. We also have a situation where at that same time we are trying to transform our system from one thing into another. And the modelling that sits behind some of those things is extraordinarily complex. So producing a financial plan as I would envisage it and how we would like to see it is actually a very, very complicated task that we don't have a lot of the data, tools, information and capability to do right now. However, what we do in the interim is, like we said before, we use proxies. We use what information we do have, we use our experience, we use our judgment, we use our intuition in some instances to try and figure out how this thing might look in the end. What I would go back to, however, is that Manx Care, along with all other government departments, is constrained to an annual funding cycle. And that really does limit us in terms of our ability to make some of those longer term decisions. The pay award is just one very obvious element of that. One of the Sir Jonathan Michael recommendations was to move to a 3 to 5 year funding model. And at the moment, we don't see any indication that that's likely to happen anytime soon. And I think that remains a risk for us because, as Nigel says, we're a complicated organisation. You make a change now, and in 3 years' time is when you might see the effects. So that ability to have a funding model that's secured over a 3 to 5 year period rather than this constant hamster wheel of year on year on year would allow us to make such different decisions about some of the things that we're doing. It would completely liberate us, I think.
But in fact, if I was one of the MHK sitting in government and I wasn't seeing a 5 or 10 year plan being produced, well, the average politician is just looking at what's put in front of them. And what's put in front of them at the moment is an annual mandate.
Yeah. So, as Jackie's outlined, I think we would love to be able to do that, but we can't do that for the constraints that are around us. I am very conscious of the time, and we have some additional board business that was left over from our private session that we need to conclude, and I know many people have meetings at 1. Teresa, I think you wanted to
I just wanted to just come back on that final point about what we're being asked to do against what funding. And just to assure you, in our financial submission to the department last year at budget setting, we did cost out thoroughly everything that we do as Manx Care and submitted that to the department so they could make that consideration as what was submitted to Treasury. So that number is known about what the totality of the costs of our services are. And what we're saying is we haven't got the money to do everything. So we are clear about what can't be done. So that information sits in the background of our financial planning submissions every year to the department.
Thank you very much. Thank you, everybody. If I could just ask board members to remain behind, we just need to finish some business from yesterday.